Good morning. This meeting will now come to order, this meeting of the Healthcare Affordability Advisory Committee. Good morning, happy Monday. Thank you for joining us in this new location, which has many memories for those of us who came to many Covered California board meetings. Happy St. Patrick's Day. We have many shades of green represented in the group. So the meeting's coming to order, and please note that this meeting is being recorded, and we will start with a roll call, please.
Good morning, Joan Allen.
Present.
Thank you. And to clarify on the microphones, if you press the talkie face button, as I've been told, it will turn red. And if the microphone is lit up red, that means it is a live mic. And if it's not, it is not on. Thank you. Barry Arbuckle.
Present.
Eliza Arjoyan. Eliza, I think you're joining us online. All right. Katie Bassler.
Present.
Stephanie Klein. Carmen Comsty. Adam Daughtery.
Present.
Parker Duncan Diaz.
Don't worry, that's one of my joke nicknames in the clinic.
Thank you.
Good morning, present.
Hector Flores.
Present.
Stacy Hiratas.
Present.
David Joyner. Travis Lakey.
Present.
Tam Ma. Carolyn Nava. And that was present for the record in the room. Mike O'Day.
Present.
Janice O'Malley. Marielle Riazza. Noting for the record, I believe Marielle is online. We'll give her a moment to get to her mic. Sumana Reddy.
Yes. Present.
Yolanda Richardson. Christina Rodriguez.
Present.
Karen Savage Sangwan. Andrew C.
Present.
Steve Shortell.
Present.
Sarah Sorokin. Ken Stewart. Suzanne Usage.
Present.
Renee Williams.
Thank you. So with that, we have a record of who is in attendance. And a reminder, if you're an advisory committee member who's joining online, we'd ask that you turn your camera on, please. I'd like to introduce our attending board member, Ian Lewis. Appreciate him being here in person in the room. And Sandra Hernandez is with us virtually. So as you know, board members, we have at least one affordability board member at every meeting, and they help us, they listen to the presentations and discussions and help convey your input to the board. Others here to facilitate and assist are Jane Harrington and Jean-Paul Buchanan, who's a member of our OCA legal team. I'd just like to thank our wonderful OCA team for making arrangements for us to be in this space, and also to Covered California for hosting us. We do have a few logistical-ish items about our host site here at Covered California. So please only use the open door you entered from to exit the conference room. So we are only have access to the main front lobby to enter and exit the building. Phone calls, meetings, et cetera, are prohibited in the hallways and lobby. The outdoor patio and employee break room are for Covered California employees only unless requested and approved in advance. And then we do have some outlet access, it's limited, so we know you'll take turns and share. I'd also like to inform the committee and public that Abby Yant has recently retired and has elected to discontinue her role as an advisory committee member. Moving on to our agenda. After updates from myself and Vishal, we'll have CJ Howard, OCA Assistant Deputy Director, present on the proposed hospital sector definition regulation. We'll then have presentations on OCA's recommendation for hospital sector target methodology and values. The committee will break for lunch, we hope around noon, and then upon our return, we have a presentation from Altamed's Senior Vice President and Chief Operations Officer, Efrain Telemontes, who will present on Altamed's organization cost-reducing strategies. And then in the afternoon, after that presentation, we'll have our OCA behavioral health team, which will provide the committee with updates on the quality and equity performance measurement, including the public comment feedback we've gotten. We'll then hear about work that they've done on the behavioral health definition and investment benchmark. So that is our agenda for the day. And I'm happy to move on to executive updates unless there are questions on the agenda. Okay. So I'd like to bring to folks' attention a bill that was introduced last month that relates to OCA, Assembly Bill 1415 by Assemblymember Mia Bonta and sponsored by Health Access, would make some changes to OCA's existing law. It would add some entities that are subject to the spending growth target and would allow us to collect data from those entities. So it would add healthcare systems as a new definition and allow us to collect data at the health system level. We've gotten a lot of feedback from board members and some in the discussion about the hospital sector targets that would be meaningful to not just collect at the entity level, but also the health system level. And it would also add MSOs or management services organizations to healthcare entities under the statute. And then on the cost to market impact side, you know that today healthcare entities have to provide OCA with written notice before a proposed merger or acquisition goes into effect. And AB 1415 would similarly, so in addition to the healthcare entities subject to that requirement under the statute, it would add private equity groups, hedge funds, and newly created business entities created for the purpose of the transaction. It's pretty remarkable reviewing these transactions, just the complexity of the different entities that are subject. So it would subject, again, hedge funds, private equity, and entities created specifically for the purpose of the transaction. Those entities would have to also submit to OCA about a proposed merger or acquisition. So that bill is moving its way through as we start the legislative session. Wanted to provide a few updates about the Healthcare Payments Data Program, or HPD. We reached quite a significant milestone recently. The HPD Data Release Program began accepting applications for requests to access non-public HPD data, right? So we've about to publish our 5th major public HPD report, publicly available data, and now folks can come in and ask for customized data requests. So we've started, those requests have started to flow in. Our latest HPD visualization is about services, which allows users to explore the types of healthcare services provided to Californians each year. And as always, those are available on our website. And at next week's OCA board meeting, the HPD team will provide an update to the board about how staff are using the HPD and HPD more broadly. Lots of other busy developments at OCA. On the workforce side, we issued $31 million for the Song Brown Primary Care Residency Program to 51 training programs, and we continued to get a lot of certified wellness coaches, which we're pleased about. So with that, I will turn it over to Deputy Director Vishal Pagani.
Thank you. I'll be providing an update on a few items. I'd like to first provide a brief summary of Millbank Memorial Fund's February 2025 report. If we could just go to the next slide. So this report provides some key lessons learned from multiple state efforts to slow and shift total healthcare spending. The report describes the experiences of states that have designed and implemented policies to pursue multiple targets. For example, a statewide cost growth target or benchmark, a primary care investment target, and/or the adoption of alternative payment models. And the report gathers lessons from these state experiences to inform policy development. There are three major themes in the report. The first one is regarding multi-stakeholder alignment, which requires a clear shared vision and close collaboration. One way to achieve this is by creating a vehicle for public purchaser collaboration to drive engagement of other payers and stakeholders. And then the second point they articulated was a shared vision is needed to articulate goals holistically, and that regulations can make the goals explicit and establish expectations. And then the third one was regarding enforcement, and they discuss how effective examples include an expansive data collection and monitoring approach and fostering accountability through contracting language and regulation. So taking stock of the points raised in this article, I just wanted to highlight a few ways it's worked in California. For purchaser collaboration, OCA has bi-monthly work group meetings with our state sibling departments that include DHCS, CalPERS, Covered California, and DMHC. In these meetings, we focus on OCA's proposed definitions for various topics such as alternative payment models, primary care, and behavioral health. We also focus on data collection processes and how to limit the burden on data submitters. An example of this is that we're streamlining the process for collecting APM data for Medi-Cal. DHCS has a set of requirements, OCA has a set of requirements. We've consolidated them into one single reporting mechanism. So this collaboration, in California demonstrates how we engage in alignment and how the public purchasers responsible for half the state's coverage are actively engaged in the process. And they also reinforce our efforts through including OCA's spending targets and benchmarks in their contract language with payers. And the next slide is a different is the same article, but it goes into a little more detail about which states are exactly doing what. Connecticut and Maryland have set both cost growth and primary care spending targets. And then with the actions here in California, we now join Delaware, Oregon, and Rhode Island in addressing all three areas of healthcare spending. And then just want to highlight that at next week's Healthcare Affordability Board meeting, we'll have representatives from Massachusetts and Oregon to provide the board members with an update on their respective statewide spending target programs. So now I'd like to move on to a different article, which was published in JAMA Health Forum. And it examined 14 key drivers of per capita healthcare spending across counties in the United States. The key spending drivers that researchers examined were age, disease prevalence, service utilization, and service price and intensity. Just to give you a brief description of kind of those latter two drivers. What they mean by service utilization is service volume per prevalent case, and service price and intensity was measured as spending per visit, admission, or prescription. The study found that service utilization explained a majority of the variation in spending per capita across counties, followed by service price and intensity, which explained about 1/5 of the variation. The researchers also found that increases in median income were associated with more utilization. the share of Medicare beneficiaries with Medicare Advantage was associated with less utilization. And the share of physicians who specialize in primary care was associated with lower prices and intensity of care, while MA or Medicare Advantage was associated with higher prices and intensity of care. And then lastly, for private insurance, more variation was attributed to service, price, and intensity compared to other payers. And then just going on to the next slide. So they included a figure in the article which shows factors that explain cross-county variation in spending per capita. I think going forward on the slides. So we see, I'll just wait for figure 2 to show up. I think two more slides. Okay. There's 3 different graphs that show different types of factors. I'll just focus on graph A, which shows payer-specific variation. For this graph, in graph A for private and out-of-pocket spending, there was more variation in spending that could be attributed to service, price, and intensity than other payers. The authors noted that this study provides signals for where cost containment strategies might be viable. They also noted that future research could focus on whether there are optimal rates of utilization and price and intensity of care that provide better outcomes. And then shifting gears to the next slide. So I just want to, provide members of the public and the advisory committee that we'll denote slides with a blue area for which we're seeking your input and feedback based on kind of the statutes, requirements, and other areas where the board is seeking your input. And now I'll return it back to our facilitator to facilitate any questions regarding the updates.
Any discussion from the committee?
With the public purchaser collaboration, has there been any thought about a statewide GPO? Because if we could reduce the cost of our supplies, it definitely helps control our costs.
Yep, thanks, Travis. There are some efforts at DGS with county governments and purchasing that we're aware of. A GPO hasn't been explored, but we could take that back to our partners at DGS.
Others, Stephen?
Yeah, just want two brief comments. One is just to congratulate all the work you guys and others are doing in the state on alignment issues, and it's spilling over to a lot of other initiatives as well. For example, the one now that IHA and about 11 or 3 health plans, I think, and PBGH are doing around primary care with the California Quality Collaborative as an example also. And that'll be interesting to see. They're working with over 100 practices, many of them small and rural practices in the state, and a lot of technical assistance involved with that as well. So that's another example. And on the JAMA Health Forum study that Michelle briefly highlights, just a reminder to all of us, prices get a lot of attention. We know, they can lead or are associated with higher prices, et cetera, with consolidation and so on. But a lot can be done on the utilization side. And the fact they found that is a bigger factor, at least in explaining the differences across counties in the United States. So we have to remind ourselves that spending is price times utilization, including intensity as well. So just a brief underscoring that.
Others? Hector, go ahead.
Thank you. Yeah, that was I'm following on Steve's comment. We'll have a discussion later today on this issue, but the level of integration really leads to more efficiency. The problem is that there's a tipping point where that integration becomes monopolistic behavior, right? So obviously that's the charge of OCA and our advisory committee as well. Um, the second part is that once they reach a certain size, they start to really price certain sectors out of the market, particularly, as a physician, practices like mine and others have a real difficult time recruiting and retaining physicians because these larger organizations, more efficient, more integrated, they're also able to drive higher salaries and it really destabilizes the workforce. And I know that's part of the charge of OCA. So just wanted to highlight that, and I know it'll be part of future discussions, including today. Thank you.
Thank you, Marielle.
Yeah, thank you so much for this overview of the report. And I'm going to have to agree also with Hector Flores regarding his concerns. In addition to that, I'd like some more clarity on where are we, slide 7, the second to last bullet point, increases in median income were associated with more utilization, except for emergency department and hospital inpatient care. Can we have more clarity on, how relative are these increases and or non-decreases between utilization and median income? Is that something that someone can answer?
We're happy to follow up, but I just wanted to make sure I understood the question. So you're asking kind of how relevant the increases in utilization are as it relates to median household income?
Right. Because my concern, right, is that folks who may not have met a certain income, right, are not utilizing as much, which is typically the issue that we see, except for emergency department and hospital inpatient care. And so, what we typically see clinically, right, is folks who, for whatever reason, don't have consistent access to healthcare or healthcare at all. They delay, right? So they're not utilizing until things get really, really bad. And that is when they go to the emergency department or are maybe hospitalized in inpatient care. So, that's great that we're seeing increases in median income with more utilization, but, we're leaving out a huge chunk of people who are already struggling to utilize because of the costs and then are forced to go to the emergency department where we have the highest drivers of cost. So I'd like more clarity on this point, how these, again, median income is being impacted by utilization, and also what does that mean exactly for emergency department and hospital inpatient care? That I'd like more clarity on what that statement means.
Yeah, we could share the article with you and the relevant portions where they address that topic. But the general sense that I got from the article was as incomes go up, people use more care. But yeah, we understand kind of the point you're making about lower income consumers facing more barriers.
Okay, I appreciate that. Is there, I guess the reason why I'm really focusing on this is it's a focus on the increases in median income, but we know that there's so many people today who are struggling with employment and so many other things happening, right? So I would like to know what's happening as well with median income decreasing. Do we have numbers for that? And I understand if it's limited, but I think, we've got to kind of keep in mind, right? Great utilization is great, but what's happening to folks who are not having, who don't have these resources? Anyway, I think I made my point, but I'm just, I want to dive deeper into that. If that could be, I don't know if that's going to be discussed later on.
Thank you. We'll follow up with the specific points in the article.
Okay, thank you.
Thank you. Other comments, questions from the committee? All right, seeing none, hearing none at this time. That takes us to public comment on this item. We will now recognize members of the public for comment on this agenda item. Please reserve comments for other items to the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which your hands were raised. During the public comment period, you will be unmuted when it is your turn. We also invite you to provide written comment at the email address on the agenda posted online today. Please keep your comments to 2 minutes or less so that we can hear from as many members of the public as possible. Please note, while the Healthcare Affordability Advisory Committee is committed to communication and transparency, members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I will now look to the podium. Seeing no one at the podium, looking online for any hands raised. Seeing no one at this time, that concludes public comment on this item.
All right, good morning. My name is CJ Howard. I'm the Assistant Deputy Director over the Healthcare Spending Targets branch within the Office of Healthcare Affordability. The first agenda item that I'll be presenting on this morning is just a brief update on the proposed hospital sector definition regulations. You can move to the next slide. In January, as many of you know, the board voted to establish hospitals as a sector. In February, the office published draft regulation text and shared the text with the board at the February board meeting. The office held a public workshop on March 3rd, and the public comment period closed on March 11th. We'll be preparing a summary of public comments received and are preparing to submit the rulemaking documents to the Office of Administrative Law for the regulations to ultimately become effective in spring of this year. On the next slide is the proposed regulatory text to further the board's motion and vote to establish hospitals as a sector in Health and Safety Code Section 1250 et sec. The proposed sector will include general acute care hospitals, acute psychiatric hospitals, special hospitals, chemical dependency recovery hospitals, and psychiatric health facilities. That concludes my update. If there are any questions, happy to, or comments, happy to entertain those now.
Any comments, questions from the committee on this item? Got a hand raised. Eliza, online, go ahead.
Good morning. Can you refresh why we chose not to include LTAC here? Under special hospitals?
Eliza, by LTAC, do you mean long-term care?
I do.
Okay. Yeah, if you could elaborate on kind of for long-term care facilities, you would describe them as a hospital. Because we're aware of other models where it's like a general acute care, but then they have long-term care beds within them.
Yes, correct. And they add quite a bit of cost to the system, and you know, considering them as hospitals under the specialty category, or even just doing the work to decide whether or not they should be included is something I think we ought to look at.
Good morning. I'm Sheila Tatayan, and I am the Assistant Deputy Director for the Compliance Branch. I know most of you. So for that question, if you look at the statute, special hospitals is included within the definition, but special hospital is not currently used for any hospital. Right now, there's no such thing as a special hospital, but there may be in the future. So we are sticking with the statute. Everything aligns with the statute because that's what regs have to do. So we looked at the definitions in 1250 of hospitals. For LTACs, they're not considered a special hospital, and specialty hospital isn't a term that industry's kind of created. So for those, if they're part of a general acute care hospital, they would meet the definition of 1250. Because, as you know, there are facilities, general acute care facilities that have those as part of their general acute care facility. If they may be separate from a general acute care facility, they might not fall within the 1250 definition, but that's how the statute 1250 was drafted to define hospitals. So our regulation includes every hospital defined within 1250 of the Health and Safety Code.
Thank you.
Thank you. Others? All right, seeing no hands raised and no one at the podium, that concludes. Are you stepping to the podium for a public comment? Okay. We'll pause for a moment.
Beth Capel for Health Access. We support the proposed regulation defining all hospitals as general acute care as hospitals for the purpose of defining sector. And that includes Kaiser hospitals. Our understanding is it also includes long-term care, acute care hospitals as distinguished from skilled nursing facilities. Thank you.
Thank you, and apologies, I didn't officially kick off public comment there before I closed it. So making sure there's plenty of time for public comment. Seeing no hands raised at this time, would you like to, step to the podium? And press the, it should turn red for you. Great.
There we go. Ben Johnson, California Hospital Association. California hospitals oppose the establishment of a hospital sector at this time, given that it comes years ahead of schedule and before OCA has done major pieces of due diligence. OCA has not analyzed a single period of spending trends using its principal data source, the total healthcare expenditure data, which would allow it to more comprehensively analyze spending trends, including by service category. HOCA has not considered any other sector, revealing a worrying partiality against just one segment of the healthcare sector or field, and a disregard from employing comprehensive and data-formed approach. HOCA has not finalized its approach for measuring hospital spending, meaning neither hospitals nor OCA know what hospital spending would be limited to and of the potential effects on hospital spending. So for these reasons, hospitals oppose the sector establishment at this time and look forward to continued conversations. Thank you.
Thank you. Continuing public comment. If you are online, raise your hand or press *5 if you're calling in. Look into the podium. Seeing no one at the podium and no hands raised online. That concludes public comment on this item. We will move to agenda item number 4.
Thank you, Jane. All right, so moving on, I'm going to provide an overview of OCA's recommendation for hospital sector target setting methodology and sector target values. We can go to the next slide. So in February, OCA presented its recommended methodology for identifying high-cost hospitals and the methodology for adjusting target values for those hospitals to the board members. That started a 45-day public comment window, which will close on April 11th of 2025. The board will have until June 1 to set targets for 2026 and can set targets for beyond 2026 at that time. Today, we will be presenting the same recommended methodology to solicit feedback from the advisory committee and the members present in the room and online. So there's a little bit of level setting to to set target values and adjust target values. The board needs to consider 2 primary questions. One is how to identify disproportionately high cost hospitals that may merit a lower target, and then how to determine sector target values and adjusting for disproportionately high cost hospitals. So our recommendation has 5 key points. The first is OCA recommends identifying outlier hospitals as those that are above the 85th percentile. The 85th percentile approximates one standard deviation above the mean. OCA recommends identifying repeat outliers as those that are above the 85th percentile for 3 out of 5 years from 2018 to 2022 on both a unit and relative price measure. Selecting hospitals that are outliers for 3 or more years identifies hospitals with systematically high costs. Next slide. OCA recommends measuring unit price based on the measure commercial inpatient net patient revenue per case mix adjusted discharge and relative price based on the measure commercial to Medicare payment to cost ratio. Using both measures identifies hospitals that have consistently high costs across multiple measures. OCA recommends a payer mix threshold of 5%. A hospital's share of revenue needs to come from a broad payer mix for the commercial to Medicare payment to cost ratio measure to be credible. And OCA recommends excluding non-comparable hospitals from this analysis. Comparable financial data is not available for Kaiser hospitals, long-term care emphasis hospitals, psychiatric facilities, Shriners, and state hospitals. Once we apply these 5 steps, this approach identifies 11 hospitals as repeatedly disproportionately high cost outliers. The next slide will show these 11 facilities and how they rank on the commercial inpatient net patient revenue per case mix adjusted discharge. We note that most of the facilities are outliers or in the 85th percentile for 5 out of 5 years, with a couple of exceptions. One is only for 4 out of 5 years and 2 for 3 out of 5 years. We also note that there are some market differences which we're exploring and investigating at the board's behest, and we'll be reporting back to the board later this month on where there's been a change in the more recent years for a couple of facilities. And so we're still in the process of investigating those. I will also note that the average for these 11 high-cost facilities of their commercial inpatient NPR per CMAD is almost twice that of all other comparable hospitals. Next slide shows the commercial to Medicare payment to cost ratio for these 11 facilities. Again, most facilities are in the 85th percentile for 5 out of 5 years. 2 of them for 3 out of 5 and 1 for 4 out of 5 years. And again, there's a couple of facilities that we're still investigating some changes in their more recent data that were submitted. We've validated internally that the way that we've calculated the data is in line with what was submitted to us, but we're investigating if there may be some other underlying root causes in there. So that's how we identified the 11, we've identified 11 high cost facilities based off of those key metrics. And so then if we've identified those facilities, then the next step would be to discuss how to potentially adjust their target and also thinking about the target for the sector. So if we could go to the next slide. Yes, sir.
Can you just explain the 5% payer mix threshold? I didn't quite get that. Could you explain that again?
Yeah, so the payment to cost ratio is a ratio of the cost coverage of revenues, commercial revenues to commercial costs, and then it's also Medicare revenues to Medicare costs. In order for those, so it's a ratio of ratios, which will make most of our minds bend on this Monday morning. But in order for those ratio of ratios to be valid, there needs to be sort of adequate or substantial revenues from both. Otherwise, the ratio could be skewed with sort of limited data or a limited data set.
Does that mean then that, like, for example, the commercial have to be at least 5% of revenue and the Medicare has to be 5% of revenue? Both of them have to be greater than that threshold?
Correct.
Okay, thank you. I understand that.
You mentioned exploring some potential market variations. Are you able to expand on any of those, or are there any that you're looking at preliminarily now, just for more information between the hospitals that you said the board directed you to explore some specific?
So specifically, we were looking at North Bay. We noticed that there's a drop off. Again, we're still investigating why there was that drop off, and we'll be reporting back to the board shortly.
Okay.
So as we think about setting target values, OCO recommends setting the hospital sector target equal to the statewide target, to which they are already subject. Setting the hospital sector target equal to the statewide target clarifies that hospitals in the sector are subject to the statewide target unless and until the board modifies the spending target for the entire hospital sector or specific hospitals within the sector. Next slide. So we also recommend a formula-based approach to adjusting the targets for the high-cost hospitals. OCO recommends that the target value for high-cost hospitals be based on the statewide spending target and adjusted according to the average cost relativity of the included hospitals. So let me define cost relativity. So for example, the hospitals could be assigned a cost relativity tied to the California statewide mean for commercial inpatient NPR per CMAD or other measure or combination of measures, as we'll see. So in this scenario, if the statewide spending target for 2025 is 3.5%, and if a hospital is on average twice the statewide mean on commercial inpatient NPR per CMAD, they could be assigned a cost relativity of 2. And then the hospital's target would be adjusted as follows. We would take the 3.5% statewide spending target, divide that by the cost relativity metric, and that would yield a final result of 1.75%.
And CJ, I see Eliza's hand raised online. Do you want to take a question?
Sure.
Hi, CJ. We can come back to it. I just wanted to spend a few more minutes on the identifying the high-cost hospital list. So wherever it makes sense for us to go back to that. Or if you
Great,
want
and
to.
we're gonna have plenty of time once I get through all of this, because I think it's sometimes easier to talk about this in as a whole. So yeah, happy to come back to it. So if we move to the next slide, so that was sort of just a primer on cost relativity. So OCO recommends the following steps for setting a target value for the identified high-cost hospitals that compares the identified group of hospitals that are repeat outliers on both the unit and relative price measures with the other hospitals in the sector. So the first step, and the next slide will actually show the math of this, and so hopefully the word soup will become easier to follow with the math on the next slide. But so first step is to divide the identified high-cost hospitals' average commercial NPR per CMAD, weighted by the number of inpatient discharges for the 5-year period of 2018 to 2022 by the outcome of all other comparable hospitals' average commercial inpatient NPR per CMAD, also weighted by the number of inpatient discharges for the same 5-year period. So that'll give us the cost relativity for the commercial NPR per CMAD. And then we also calculate the cost relativity based off of the commercial Medicare payment to cost ratio, again, weighted by the inpatient discharges from 2018 to 2022. So now we have two cost relativity metrics. In step 3, we average those two outcomes. And then we would divide that by the statewide spending target for each applicable year to come up with a recommended target value for each target year. So in the next slide, this is how the math works out. So we start with the weighted average commercial inpatient NPR per CMAD of all of the high-cost hospitals, which is $40,200. We then divide that by the weighted average commercial NPR for all other hospitals. So that gives us a cost relativity of 2. We have the weighted average commercial to Medicare payment to cost ratio of the high cost hospitals, which is 350%. We divide that by the weighted average commercial Medicare payment to cost ratio for all other hospitals of 200%. That gives us 1.8. The average of 2 and 1.8 is 1.9. And then we divide the applicable annual spending target by 1.9. So in 2026, that would yield a target value of 1.8. In 2027 and 2028, that would yield a target value of 1.7. And in 2029, that would yield a target value of 1.6. We go to the next slide. So under the status quo, the high cost facilities would continue to grow no more than the statewide spending target, but are doing so from a higher baseline level. Further limiting the rate of growth to these hospitals would bring the costs incurred by consumers for these hospitals more in line with the broader hospital sector, thereby reducing historical inequities between high cost facilities and more efficient facilities. Lower costs from a slower rate of growth promotes more equitable access to more affordable care for Californians, and rooting the adjustment methodology in the statewide target underscores the principle of consumer affordability, as the statewide target is based on the median household income growth, the key metric of consumer affordability. We also, in the next slide, we also recommend that we should align the adjusted target values with the current statewide spending target schedule, so from 2026 to 2029. A multi-year target provides hospitals long-term predictability. Knowing the target value in advance encourages cooperation within the healthcare industry to meet the targets and allows the hospitals to influence negotiations for contracting and inform strategic planning and operations. Just like with the statewide target, in the event of extraordinary circumstances, including highly significant changes in the economy or the healthcare system, the board may consider changes to the target. OCA recommends that the board meet annually to consider any needed updates to the target, including adjustments for unforeseen circumstances. The next slide is a summary of all that, showing the 11 facilities, showing the recommended target values by performance year. And on the next slide, this opens up the advisory committee discussion. So does the advisory committee have input on OCA's recommendations for identifying high-cost hospitals and setting and adjusting sector target values?
So Eliza, I see you still have your hand raised. If you'd like to kick us off, and then we'll go to Andrew.
I do, thank you. So going back to how we identify the high-cost hospitals, as we look at the 11, all of them, with the exception of one, are in Northern California. And so if we're going to move from the 80th percentile to the 85th percentile, the one recommendation I would like to have be taken into consideration is that we also include a geographic examination for Northern versus Southern California, in supporting the production of maybe a few more hospitals that are high cost outliers for both regions, just in the spirit of sort of equality and fairness, because there are, few hospitals in Southern California that are also high cost with respect to outliers. And so just making sure that we're looking at a well-rounded approach would be my recommendation. Thank you.
Thank you. We've got Andrew, then Stacy, Joan, Hector, Katie, and Simona.
Sorry, I have a couple of comments. Some are probably questions. The first off, I don't know. I'm an actuary, so the 85th percentile appeals to me, right? Because it's right around one standard deviation. So thank you for that. The commercial inpatient net patient revenue, it seems kind of as a measure probably not complete to me. Just you have to have all lines of business, right? Because the commercial payment isn't really independent of Medicare, Medicaid, at least not in the long term. The other thing is, the exclusion of outpatient, it's kind of not small, right? Because all of the volume, it's at least half the volume, and that's kind of where things are shifting. So we probably want something a little more complete. The other thing is, I guess I don't remember the percentage of Medicare, if that's inpatient only or if that's both inpatient and outpatient. I think it's probably both, right? But just wanted to clarify that. On the multiple year, I guess I like multiple year. I probably am more biased to a rolling 3 as opposed to 3 out of 5, because you end up with situations where I think you have a couple hospitals where their most recent is really significantly below the historical. And, you have to think through, the hospital is not just on the list, but on the bubble, right? So it's kind of like a rolling 3 is probably more recent. What else did I have? Oh, and kind of just the process for updating the list. Is it a yearly thing? And also, does everybody get the same target? This looks like they are, and some are more outlier than others. So, I guess I don't know if hospital specific is in the cards, but that's just a question.
So yeah, Andrew, with regard to your question about kind of, is it going to be a yearly exercise? So yeah, we're still having conversations with the board if they would like this to be a yearly thing or on some other cadence, like every 2 years. And then regarding your question about like outpatient not being included in the PTCR, I believe outpatient revenue is. We could get back to you on that, but were you flagging that it's more inpatient based or?
Yeah, I think the first measure is definitely inpatient only. So I think
Yeah,
it's
the first
kind of,
one is.
yeah, it's kind of incomplete, right? And
Yeah.
from a consumer perspective, you have a deductible plan. Inpatient, it's not gonna kind of make a difference because you hit the out of pocket before you hit the elevator. But you know, the ED, outpatient surgery, that's the stuff that could be under the deductible that could actually really impact a consumer. And then the other one is just a percentage of Medicare, because I thought it was both IP and OP, but there's just confirmation.
Yeah, we showed a slide in last month's board meeting, or maybe 2 meetings ago, but we did show the difference between the unit price measure and the relative price measure and the trade-offs. And for PTCR, we did flag that it one benefit of it is that it encompasses outpatient revenue.
Thank you. Stacy, Joan, Hector, Katie, and Simona.
So in the discussion for those hospitals that have capitation for both Medicare Advantage and commercial, how is that being allocated to get to net patient revenue? Because sometimes ambulance is included in the capitation rates and things that are not that hospital specific. They pay out of network claims to other hospitals. So how do you handle capitation for both Medicare Advantage and commercial?
So when a payer capitates a hospital?
Yeah.
So that's included in the net patient revenue measure. It includes kind of all revenue for the hospital.
So it includes the capitated as well as the PPO revenue, but
Yes.
how do you allocate it to I guess it's devil's in the detail of how capitation's handled, I guess, is just a flag to be concerned about.
If a system
Like
receives a capitation, and then how they allocate it to their member hospitals, or?
Correct, as well as you pay out of network claims and services that are not at your hospital. There's inpatient, outpatient. It's a market basket of services based on the division of financial responsibility. So how do you get to that number?
Yeah, if it's a service that the hospital can't provide, the HCI financials requires them to put it under purchased services. So that comes more as an expense for the hospital, not necessarily revenue, but they were responsible for providing the service. They just can't do it in-house.
So that reduces their patient revenue then?
It's still in their revenue, but it kind of becomes an expense because they had to pay for it to essentially kind of subcontract it out.
So what they're left with is less than just the capitation.
Yeah.
Right.
Yeah.
So I just am concerned for capitated, both Medicare Advantage and commercial, how that's being handled and how it's reported, and the devil's in the details. Just be careful.
Yeah, and Stacey, you're tracking that we're using the hospital financial data that hospitals submit to us under the existing rules. So we haven't changed at OCA. So we're using that data as it's reported to us, including, capitation and the like.
Okay.
Joan?
First, just want to appreciate all of the hard work that's gone into getting us to this list. This is a huge lift, and just thinking back to the presentations that we've seen over the last few months, both here and at the board meetings, and really taking the feedback, hearing people's concerns, and getting to a methodology that I can really I can really understand, and can also feel like I can explain and really defend, that getting to using case mix adjustment, making it easier to compare between hospitals, using the 3 out of 5 year threshold, stabilizing for hospitals that have that low Medicare or commercial volume. All of those feel like really good steps toward just a solid methodology. And appreciate that we're moving forward, that we're recognizing that a huge charge of this entire project is getting to the point where we're improving affordability for consumers, and see this as an incredibly important step forward. So just wanted to appreciate that. Did have one question on this list. Is HCI planning, how is HCI planning to engage with these hospitals that are on the list? Will there be technical assistance or other engagement with them in this first year, as we're trying to help them meet an ambitious target?
So right now we're having individual meetings with the hospitals. In February, we summarized some of the conversations we had to date. So those were just for 5 hospitals. Since then we're almost about to meet with all 11. And at this month's board meeting, we'll be summarizing their input on the methodology. So since no action has been taken yet on a target value, we'll continue to stew on that in terms of what level of engagement we want to have going forward.
Thank you. Hector?
Thank you. My question is, and I have a comment following it, is why we don't have Kaiser Hospital information. And the reason I think it would be really instrumental in our thinking, as many of you know, I trained at Kaiser and I stayed on as a partner and got involved administratively with a lot of the work Kaiser did. And what I was really impressed with is that they looked at their medical group and their hospitals as cost centers. And they had to do an analysis about how to be more efficient yet competitive on both ends. And on the hospital side, for example, back in the day, we were looking at daily cost of a patient in the bed was $3,000 a day, and administration and the doctors got together and said, how can we lower that cost? How can we improve efficiency to be able to continue to afford providing care to our patients? When I stepped out of Kaiser into the other form of private practice, which is where I'm now, the hospital behavior was really more about, how can we maximize or optimize our charges to Medicare, et cetera, health plans, and commercial, on the commercial side in particular. And invariably, the conversation shifts to Medicare doesn't pay us enough. Medi-Cal, we know we lose money on. We got a cost shift to the commercial side. And the problem there is that there is very little thinking about how to really reduce those costs and produce some value to the consumer. To Marielle's earlier comment, we really need to look at, because the cost shift is happening constantly on the commercial side, and employers and health plans are coming up with devices that protect the employer by a fixed premium contribution, for example, but the increases are being shouldered by the worker and their family. And that's what makes healthcare so unaffordable. And I really think that it's important to look at systems like Kaiser that look at their hospitals as cost centers, looking for those efficiencies. They don't need to have all the bells and whistles to recruit commercial or private paying customers with money. They're really just looking at how do we provide good, solid medicine for our consumers. I think it's really be valuable if we could get that information.
Thanks, Hector. So at the last one of the board meetings, we did touch on the issue of Kaiser. So the hospitals are included in the sector, but they weren't part of this analysis for a high-cost hospital. The statute requires us to treat them as a fully integrated delivery system. So we'll, should the board want to go in that direction, they could set a fully integrated delivery system sector. But we'll still be reporting on Kaiser hospitals individually as part of reporting the HCI financials. There are a few changes in state law recently where they're no longer aggregated at a higher system level, that they do report specific data with respect to each facility. So we'll have more of that granular data to report on Kaiser along with the other hospitals in California.
Thank you.
Okay, we've got Katie, Simona, Stephen, Carmen, David, Barry, Marielle, Suzanne. Katie, you're up.
Good morning. I want to echo the comments of both Joan and Hector and appreciate the board's work coming from Monterey County. Slide 25 is essential for us. We are starting at such a high cost baseline that there's such urgency. I just wanted to share with the board that in the 6 o'clock hour this morning, I got a call from a member having to go to ER at the community hospital and wondering where she should go, both to save our healthcare plan and herself. So the charge of the board is accessibility and affordability, and this is such a huge step. So I support this methodology and look forward to continued savings for everyone throughout California. Thank you.
Thank you, Simona.
Thank you again for all the work, and agreeing with previous speakers, Joan brought up actually my main thought around technical assistance, and it also underscores Hector's comments on cost shifting justifications versus cost reductions and offering real value in doing that work. And I've respected Kaiser for that, aspect. So supporting the historical look, and I personally was really thinking about this 3 out of 5 years thing, because in my 35 years in the county, these two hospitals have been the highest all along, right? Like that kind of outlier. And so it really has me thinking about the local healthcare culture that has led to practices over decades that have to do with geographic lack of competition and inability to negotiate with them in substantive ways, right? So it just really underscores that what you're doing makes sense. And those discussions of uniqueness that, these groups feel are really underscored by the lack of insight into how others do it. So I think, you become insular, and it's hard to say that, but I've worked hard to not be insular by connecting with, other organizations and always looking at how others do things. And it's kind of ironic being, the little speck that I am, that ecosystem. So I just wanted to throw out that I think that technical assistance is in fact really important. We in primary care are vastly reorganizing ourselves to improve value when we are already very high value. So there's the work.
Thanks very much, Sumana and Joan. I do want to address that a little bit. And it's been an interesting journey the last few years as HCI stood up the distressed hospital loan program and saw the most financially distressed hospitals. And now OCA is doing this process of looking at the highest cost hospitals. And we really are trying to glean the trends of what's going on with the distressed hospitals and what's going on with the hospitals that are so high cost. And so in terms of technical assistance, we'll absolutely continue to provide technical assistance about the data reporting and the data. I do want to temper expectations. We're not here to tell hospitals how to run themselves, right? And so I think it's been wonderful. You all are each other's best resources. I'm happy that we've been able to bring the examples of cost reducing strategies, and we're very interested in that. And as the state, we want to see systems succeed. I think the associations have a really important role to play in terms of bringing folks together and lessons learned. And OCA, we are not going to tell hospitals how to run themselves. And I think there's been important discussion among the board members that we're putting faith, we're saying that the cost measures need to be achieved, and there are lots of ways of doing it. And we are not prescribing exactly how to do it. So I just wanted to make that point.
Stephen?
Oh, is this on? Let's see. Is it on now? Yes. Okay, it's on. Continuous improvement. Yep. Good message. A curiosity question. I guess all questions are curiosity questions, but then a request. So I'm just curious, you did the 1 standard deviation, you got a list of 11. What would you get if you did 2 standard deviations? Would that go down to 3 or 4 hospitals? It's just curious. Anybody have that data? Easy to do.
We've done, I don't know that we have it at our fingertips, but I know that it's quite a small number.
Yeah, unfortunately, I hate to give a plug back to the January board slide or the February board slides, but we did include just the descriptive statistics along the lines of what the unit price and the commercial to Medicare payment to cost ratio looks like. 1, 2 standard deviations, as well as just given the non-normality of the distribution, what does it look like when you're taking the difference between the 3rd and 1st quartile and then multiplying it by a scalar factor of about 0.25. And so you get kind of a range of different ways of thinking about the distribution. I don't want to speak extemporaneously and misquote the numbers, but they are available in the January board slides.
Okay, just curious how much it maybe went down to 3 or 4, or not, how sensitive it was.
It would naturally be.
So my request is, in terms of future meetings, can we take a look at the low cost outliers going the other way? 1 standard deviation, low cost, 3, 4, 5 years, whatever, or even 2 standard deviations, but at least 1 standard deviation. What can we learn from them along the lines of the recent discussion as well? And it'd be good maybe to have 1 or more of them come, as ultimate is today, to talk about how over 3, 4, 5 years, they've continually been lower cost and without compromising quality, looking at the equity and quality measures as well.
Thank you for that suggestion.
Thank you. We've got Carmen, David, Barry, Marielle, Susanna, and Katie.
Thank you for all the work in putting together this methodology. It's very helpful, and it's definitely in the direction that we've wanted OCA to go. I do want to just flag a couple things that apologies, I forgot who mentioned Kaiser, but making sure that we look in the future of creating the integrated healthcare delivery or whatever the definition is for Kaiser, that Kaiser falls under. I think it's important because we don't want to leave out that big component in terms of making sure that we're not creating the false impression that Kaiser is within and not an outlier. I do want to flag one question that in the future that I think is really important is, like a few of those hospitals are hospitals that are listed in the outliers are hospitals within systems. So I think it'd be important to kind of broaden an analysis in the future to understand how hospitals that operate within a system may or may not, they have increased ability to be able to potentially move money around between hospitals. And I think it's important to get a system analysis of these of hospital systems and how perhaps there's an outlier hospital or there's some sort of shifting of cost within particularly outpatient types of services. So I think it's important to include kind of an analysis of where hospitals within a system lie. And then I think if you all are reaching out and trying to do technical assistance with individual hospitals that are on this list, particularly because we're also just starting with the workforce stability standards and getting data on that, it's important to engage labor and making sure that these hospitals, this is the first round that we're going to do growth targets, and making sure that these hospitals, when they're seeking to reduce their costs, that they are, as we've been saying for however for years now, which is that they don't do it by either cutting labor or cutting the workforce and impacting those workforce stability standards. I think this is really a place where we need to figure out where the rubber hits the road in terms of how the workforce stability standards interplay with the individual hospital targets, in particular the slower target, or I know we're talking about it when we're talking about Monterey, but I think this is where we're going to figure out the process in terms of engaging in that, and then obviously also engaging with the community and patients that are in the area. I think is really important, and I think it's a good time for us to start thinking about those things. Thanks,
David.
Yeah, I got kind of two questions and a comment. First question is, I know the inpatient is case mix adjusted. Do you have a feel for how effective that is in adjusting for different lines of business? So the thing I'm thinking about, for example, Stanford Hospital is a trauma center, and it also does a lot of transplants, which a lot of the other hospitals on the list don't do. Some of them, but probably not the same scale. So do you think the case mix adjusted is sensitive enough to adjust for pretty significant differences in the kind of services the hospitals are providing?
Yes, it's an example of Stanford. Their CMI is in the number 2, like 2 point something kind of value. We included it in last month's board deck. So the weights that we're applying are the MSDRG weights, Medicare severity diagnosis related group weights. For children's hospitals, it may not be the best kind of weighting to use. So we're looking into other ones such as the 3M APR weights, all payer relative weights. But it is a pretty recognized kind of way to apply for inpatient intensity.
Okay, thank you for that. Second is just to double down on Andrew's point about outpatient. I think the methodology is definitely tilted towards inpatient, but as I'm sure most people are aware here, more and more services are moving from inpatient to outpatient. And I think for many hospitals, the outpatient revenue is a very significant part of total revenue. So I think if you're looking at the whole picture of healthcare affordability, you've got to make sure this methodology doesn't miss or under account for outpatient. And over these next 4 years, there's just a continual migration, things like hip replacements and so on, moving from inpatient to outpatient. I want to make sure the methodology doesn't miss that dynamic.
Yeah, well, this methodology for high cost hospitals is using these two measures, but we do, in terms of year-over-year measurement, we do need to also look at both inpatient and outpatient, and we're working on that. So we'll be able to, in the future, have a way to do an outpatient intensity adjustment so that we can get to that outpatient per unit measure so that we could do the year-over-year measurement.
The other thing I wanted to say is, as an English expression, you can't have your cake and eat it too. So I feel that there seems to be, in some of the comments made, a thought where we could reduce the rate of increase in costs, but not touch labor. And that is, to me, fanciful thinking. For at least for a physician group, labor is like 85% of our costs. For a hospital, it's probably 60, 70%, I'm guessing. I'm not a hospital CEO. There's others in the room who could correct me on that. But I think the idea that you can sort of significantly, these numbers are way below inflation and way below medical cost inflation. So if you're going to, as a hospital CEO, try to meet that target, to me, it's unavoidable. You're going to impact labor costs, and this idea that we're going to have these labor standards, and those are going to be sacrosanct. and at the same time going to meet this dramatic reduction in healthcare cost inflation. I just don't think those things are reconcilable. So I think we need an honest conversation about if we really want to achieve these pretty radical reductions in trend, you can't do that without impacting labor in some way. So I just want to bring that issue in for the discussion.
Barry?
A couple of comments. Dr. Chotel's request, which you seem to embrace, about looking at some of the low-cost hospitals and trying to understand how they, can survive there, presuming they're not in the 54% that are running in the negative on an operating margin in the state. What will be interesting to see, I think, going forward is if we do that, given that those hospitals experience the same inflationary pressures as the higher cost hospitals, they have less revenue per discharge to move that money around and cover those inflationary pressures, and fewer dials to turn, because presumably they've turned those dials over many, many years so as to have a lower commercial inpatient net patient revenue, to see if those hospitals are the ones that show up on the lists of exceeding your 3.5% or your 3%, because they have to in order to continue to survive. So it'll be an interesting, I think, dynamic to look at. I like others have, I too would argue for including hospital-based outpatient. When we say outpatient, we're an acute care hospital, we're talking about hospital-based outpatient, not community-based outpatient. But given the movement of business from inpatient to HOPD to community-based outpatient, and what's happening in Washington, D.C. with chainsaws flying around, it's entirely likely we'll see the elimination of the CMS inpatient-only list, which is going to move a big bolus of business from inpatient to probably hospital outpatient before it goes to community-based outpatient. So again, that dynamic, I think, is important for us to keep track on. And then finally, I'm assuming, I may be wrong, but I'm assuming that one of the primary reasons to narrow or have this list of these today 11 high-cost hospitals is to narrow the list that OCA staff and consultants will need to audit and interact with, and try to wade through what will be scores, if not hundreds, of reasons why they are higher cost hospitals, all the explanations that you have to try to sort through. And what concerns me a little bit is this use of a kind of this hybrid approach with the Medicare, the ratio. As I've mentioned in past meetings, Medicare is not equitable, nor is it terribly sensible in terms of the way it reimburses hospitals differentially for the same procedure on the same patient in two different hospitals. And I think witness of that is if you look at what I think OCA's primary focus is, and that is the commercial prices to the employers and the consumers. This approach that led to these 11 high-cost hospitals eliminated the higher commercial cost hospitals, as was shared in the January advisory committee meeting. The number 3 highest hospital, the number 6 highest hospital, the number 8 highest hospital, the number 9th highest hospital were all eliminated by that approach, which to me seems inconsistent with a focus that OCA seems to have, and that is the commercial impact on employers and consumers.
Thank you. Marielle?
Hi, thank you again for this very detailed presentation, and I also appreciate all the comments that were made before me, and I'm going to have to agree with all of the concerns about how we're looking at this data, which data are we looking at, how we're comparing some of this data. One of my concerns, and I'll just add to some of the things that have already been said, right, as while we're looking at hospital spending, how again is it being compared to how costs are being shifted to out-of-pocket costs? So, if we can't have that picture of what is actually being offset to consumers, then I don't really think that we're looking at it entirely. So I'm just adding to everyone's point that we really need to look at these other data and compare them all together. And I worry that when we do it piecemeal by piecemeal, right, we miss a lot of important nuances. So again, just pleading with everyone and agreeing with everyone on additional data to be able to compare. And of course, I'll look at workforce. You know, there's so many factors here, and I get that it's hard to present all of this data at once because it's already very diluted. I mean, convoluted. I'm not familiar with every single term, so I'm here like looking up things. But you know, I think in the spirit of also just trying to make all of these meetings inclusive, right? I wouldn't mind if there was another, like, I don't know, a glossary of things or in addition, because, you know, I'm listening here and I consider myself a relatively educated person, but there are still a lot of things for us to dive into. So I guess my comment is ending here with agreement with all the comments before, but also is there a way that we can also spend more time or have some kind of additional document defining certain terms so that we can look at all of this data together and cohesively and be able to visualize them much better. Thank you.
Yeah, thanks for that suggestion. And we know there's too much of an alphabet soup in healthcare. And so we have tried to do some of that along the way, you know, defining net patient revenue and CMET, the case mix adjustment. But it's a good reminder to try to have it be as explainable and understandable. Appreciate that Joan finds it presentable, and we're trying to get there. And also just wanted, you know, all of your feedback is incredibly helpful, and also just want to make sure folks are flagging the piece that CJ went over, that we're in this 45-day comment period. So really appreciate folks who want to weigh in with specific suggestions about changes by April 11th. That'll be very helpful to us as well.
Thank you, Suzanne, Hector, and Travis.
Thank you. I just wanted to appreciate the work and development of methodology, especially the commercial to Medicare PTCR. There's a little added acronym that we've created. Given that the sheer volume of the studies on medical trend increases, not just specific to California, do emphasize this, you know, whatever lingo someone might find appropriate. A lot of times it's coded language about payer mix, cost shifting, et cetera. So I think that really helps like set a baseline. But I also definitely reflect the ideas of developing outpatient cost and understanding how that affects it. But I also wanted to emphasize the director's comments on the execution not being part of this. And then we want to focus on the data and measurements, not how like a hospital might actually achieve it, because different appropriateness of care, the differences of income brought up in the Milbank study. I think that I've done a lot of studies on differences of income, and it's, yes, if you have lower income, you're delaying care, but the higher income, the more inappropriate or necessary care you may be getting as well. So I think being able to allow hospitals and I am not a direct healthcare professional, so allowing the professionals to determine what the best ways to approach this and having quality over quantity and whatnot may help affect these costs over the long run. Solid. Because really the methodology opened up for me the idea of not just addressing outliers, but I was wondering, maybe this is where the question, a little bit of the question is about the consideration for developing, using this methodology ongoing, not just for outliers, but being able to look at specificity in maybe those who are just above 250% of Medicare, if we're looking at that PTCR metric. And assuming this continues past 2029, that if you are able to adjust, then it kind of scrunches the bell curve, which is, I think, what all of us are trying to do, and allows everyone to be treated a bit more equitably, right? That it's a percentage of what your increases are year over year. So if somebody starts at the higher bar, like we were talking about earlier, it'd be advisable to have them kind of get back to the regressive mean. And I just wanted to, one other small comment is that the hospital systems, to Stacy's point, I do completely understand that the capitation or Medicare Advantage does play a factor. I don't know the answer to it at all, but I do know that I guess this cycles back to the first comment I made, that Medicare Advantage has now shown with its success also a challenge in pushing more fee for service. So I think that's just as much a part of it as just understanding that capitation is complex. It also has created higher costs on fee for service and more of this cost shifting and payment. So I think this is only the perfect time to kind of start talking about it.
Thank you. Hector and then Travis.
Thank you. Yeah, really appreciate this conversation that we're having. So wanted to touch bases on a couple of things. One, regarding the cost of labor, which is a big deal, as David Joyner mentioned earlier, for not only hospitals and physician groups like mine too. The issue is that the genie is out of the bottle. The cost of labor is what it is because California is such an expensive state to live in and to recruit staff, and the shortage makes it even worse because we're recruiting away from each other, a very limited workforce. And so a couple of things. And by the way, the labor cost also includes, the executive, the C-suite, right? We're always doing analysis of market. How can we recruit the talent we need to lead our institutions, medical groups, or hospitals? Also is a very competitive field and drives the cost of healthcare up. I think what we need to look at as an advisory committee and OCA, the board itself, is to look at ways that we can reduce costs that are manageable. For example, at White Memorial, which is a safety net hospital where I work, about 20% of the labor cost is related to the fact that White Memorial can't retain nurses. So the hospital's engaging traveler nurses and registry nurses, which are always going to be more expensive. Same thing with vendors for other services. And I can attest to the fact that the nurses who work with me and my patients are worth every penny that they're paid because they take great care of the patients. So we have to kind of recognize that genie is out of the bottle. What we need to do then is say, can we work on workforce so a hospital like White Memorial doesn't have to depend on registry or traveler nurses or vendors of other services? Same thing with physicians and the physician workforce. And then also look at regulatory relief for experiments. When we had the public health emergency at the peak of the pandemic, a lot of hospitals invested in developing hospital at home programs, but it was state-specific regulations that prevented them from using them, like other states. And so I think we need to look at two big things. The workforce is how can we pull out all the stops and bring the kind of workforce that we all need? And secondly, regulatory relief for innovation so that we can actually produce a lower cost product. Thanks.
Thank you. Travis and then Marielle.
So I'm assuming extraordinary circumstances includes giant cuts to Medicaid if that comes down the line, because I do have some concerns with the timing of this and Medicaid cuts coming down the road that it's going to have horrific. We're going to lose a lot of care around the state and a lot of workforce as well. I know 40% of my revenue is Medicaid, so there's huge concerns around that.
Absolutely, and we definitely need to acknowledge the uncertainty and the anxiety that causes. So we're very aware that any significant cuts to Medicaid would have a huge impact to our Medi-Cal program and all of you that rely on those revenue.
Thank you, Marielle.
Yeah, again, just really appreciating this conversation and the really the nuance involved in all of the discussions that we're having. I wanted to add to the conversation about workforce and not even being able to hire enough nurses who are employed permanently at these hospitals, right? So I know a lot of people, young people who are trying to get into nursing, and for a number of reasons, I don't know, there's not enough nursing school positions open. We've seen something, we're still experiencing something similar with medical schools. There are more medical schools being built, that's great, but there are still not enough residency positions open year to year to be able to accommodate every single medical school graduate. So what you have an increased number of medical school graduates in the US who are, by the way, also competing with foreign medical school graduates or international medical school graduates, some of whom are American, but will maybe go to the Caribbean to go to medical school, but they're considered international medical school graduates, right? So there's not enough increase in residency positions, and so you've got a number of graduates who are not matching every year, who are not being employed or unemployable for whatever reason, right? And so, there's so many things to this issue of employment and workforce. And, while we're talking about it, there are more and more people who continue to leave because of the frustrations that they continue to experience and the pressures overhead. And, really it becomes a question of, well, as physicians, right, a lot of people don't have control over their care. And, that I believe that's been expressed over and over again here. So I just want to, kind of make a note of that, right? Because we can talk about all of these issues about workforce, but we also have to address, well, training. We're not training enough people. People are not completing enough training, right? There's so many things happening on that end. And then, on my other point is we're in a time where there is a lot of scrutiny over CEOs these days, right? Especially across healthcare and insurance companies. And so just looking over at labor costs, right, I would really also like to better understand, if that's possible, right, how much of those labor costs do go to C-suite executives, and what is the justification for that? Because what we've seen over the course of COVID, right, in the last 5 years is that these health insurance companies have continued to increase their profits exponentially, right? We've got CEOs who are making way more money throughout COVID, and this is in the healthcare industry, and that worries me, right? This to me is a really if we're not scrutinizing this, right? Our healthcare system, I don't know how many people are going to actually believe and trust what not just healthcare systems, what we're trying to do, but even clinicians, right? Because at the end of the day, we're kind of at the mercy of insurance companies, and we can plead all we want, but there's only so many hours in the day. So I would like to see, if that's possible, more scrutiny into those avenues. And again, that's training, access to training, completing training, there's so many more things to that to make these services much more accessible. But just based on these conversations, that and also the proportion of labor that's going to C-suite executives. Thank you.
Thank you. Looking for additional comments or questions from the committee. Seeing none at this time, that moves us to public comment on this item. Please step to the podium. If you're virtual, please raise your hand. Please limit comments to this agenda item and to 2 minutes as possible. To the podium, go ahead.
Beth Capel with Health Access California. Hospitals represent 40% of health insurance rates. That includes both premiums, deductibles, copays, coinsurance, and other kinds of cost sharing. That is part of the reason for the focus on hospitals. We would also note that, as we know, half of Californians today skip getting care, skip going to the doctor, skip filling a prescription, skip getting the lab test because of healthcare costs. People lack access to care today because of healthcare costs. We even see a recent and disturbing report in Health Affairs that people are skipping what are called non-avoidable emergency room visits. That means when you have a chest pain or you think you're having an attack of appendicitis, that you don't go to the emergency room when you should. This is distinguished from avoidable emergency room visits, things that could have been taken care of in the doctor's office. We have worked extensively with the staff and spoken at length with the board on the methodology as it has evolved. We are pleased with the focus on commercial costs. We think that 3 out of the last 5 years makes a lot of sense given the COVID emergency in the midst of it. These 11 hospitals are literally twice as expensive as the average hospital in California, literally twice as high. $40,000 per discharge adjusted for case mix, as opposed to $20,000 on average. These are known high-cost outliers. Most of them have been known for decades, if not years. And it's time they understood that we want hospitals, physician organizations, health plans, and insurers to think about how to reinvent care so it's more cost effective and equity and quality are improved. Some already do that, but not all. Yes, I'm well aware. We also ask that the board not delay action on this because it's gone on far too long. Thank you.
Thank you. Looking virtually, seeing no hands raised at the time, noting we have about 72 virtual attendees. We will go back to the podium.
Hi, I'm Carrie Sanders, Senior Policy Director with CPEN, the California Pan-Ethnic Health Network. I serve on the OCA Investment and Payment Work Group and want to align my comments with Kieran Savage, our Executive Director who sits on the Advisory Committee but couldn't be here today. As others have commented, we agree and strongly support the OCA proposed focus on the 11 high-cost repeat outlier hospitals. We think this is a extremely important move, and as Beth said, we would like to move forward. We don't want to see further delay. Well, this is an important step. We also urge OCA to keep the hospital sector definition targets as broad as they are and inclusive as they are as defined in the regulations. Specifically, we urge OCA to investigate psychiatric hospitals as well. These are some of the for-profit companies that are operating these hospitals, are some of the fastest growing destinations for tens of thousands of Californians. But regulations are not as stringent. And you may have seen a recent San Francisco Chronicle investigative report that found that the for-profit hospitals on average are spending less than half of what their counterparts are. And to contributing to roughly 440 million in profits. So while we believe the list of 11 hospitals is a great start, we think it's also critical for you to engage in discussion, as we engage in discussions on behavioral health spending, to really think whether there could be a subset of these hospitals whether that might be warranted and based on a common set of variables. Thanks.
Thank you. Looking virtually, seeing no hands, we'll go back to the podium.
Hi, Ben Johnson with the California Hospital Association. California's hospitals oppose the sector target proposal. This rush to adopt sector targets prior to doing proper due diligence has led to serious flaws in the methodology and the resulting list of disparately situated high-cost hospitals. The commercial to Medicare payment to cost ratio is flawed, as was discussed by several members of this committee, due to depending fully on the soundness and equity of Medicare payment policies that over time have become increasingly divorced from the realities of on-the-ground hospital financing. One hospital score has increased, for example, by 25 percentage points due to artificial caps on Medicare medical education funding. And another hospital is on the list primarily because it's paid just 30 cents on the dollar for seeing Medicare patients. Even more concerning, the spending targets proposed would inevitably endanger patient care, being 70 to 80% lower than recent cost growth for the largest essential inputs into hospital care: labor, as was discussed, drugs, medical supplies like PPE. One hospital on this list has recently reported having just 17 days cash on hand, making it highly uncertain whether the hospital could survive under these extremely aggressive proposed targets. And all of the subject hospitals would inevitably have to shed staff, cut essential service lines, and curtail investments intended to improve quality, access, and equity consequences that are ultimately antithetical to the spirit and letter of this office. Thank you.
Thank you. Looking virtually, seeing no hands raised. Give it a moment, seeing no one at the podium.
Okay, you all surprised us. This is a very efficient morning. So what we're going to do is take a 15-minute break, come back at 11 o'clock, and then we will talk about the behavioral health benchmark. And so we'll resume at 11 o'clock. Thank you. All right, let's take our seats if we can, please. And again, because our ultimate friends are coming after lunch, we're going to pivot and move to our behavioral health benchmark, and pleased to turn it over to Margareta Branch and Debbie Lindis.
Good morning, Margareta Brandt. I'm Assistant Deputy Director for Health System Performance at the Office of Healthcare Affordability. Nice to see everyone this morning. So in this portion of the agenda, Debbie and I will give you an update on the behavioral health workstream. This will include an overview of the methodology we are proposing to use to identify behavioral health spending and a progress report on the work to define the behavioral health investment benchmark. So if we could go to the next slide. So this, as we always do, starting with a reminder of our statutory requirements. So as with primary care, OCA's statute requires us to both measure the percentage of total healthcare expenditures that go towards behavioral health care and to set a benchmark for behavioral health investment that sustains infrastructure and capacity and shifts resources from specialty care towards supporting and facilitating innovation and care improvement in behavioral health. And again, on the next slide, another reminder is the investment and payment work group members that we work with. So these are the members of the investment payment work group that we meet with monthly to work through the complicated issues associated with measuring behavioral health spending and setting a benchmark. And the work group includes representatives and perspectives from providers and provider organizations, hospitals and health systems, health plans, consumer groups, academia, and state and private purchasers. And if we could go to the next slide. So this slide summarizes the key themes we heard from our board discussion in February. So we also updated the board on our progress at its February meeting. And among the feedback we received were the following points. So given that OCA plans to initially collect behavioral health spending data from commercial and Medicare Advantage payers only, the board members stressed the importance of keeping Medi-Cal in mind as we develop data collection specifications. There was also some discussion of the proposed focused behavioral health investment benchmark and interest in understanding the rationale for excluding inpatient spending from that proposal. Board members expressed interest in tracking over time spending for inpatient behavioral health, pharmacy costs, and payment rates for behavioral health services. There was also an interest in understanding from payers and providers the reasons for access gaps and low network participation, and in capturing behavioral health spending in schools. And then board members also discussed ways to track behavioral health transformation that's occurring across the state. And with this background, I'll turn the presentation over to my colleague, Debbie Lindis, Healthcare Delivery System Group Manager, to provide an overview of OCA's proposed behavioral health spending definition and methodology, and to review some of the key questions we will need to answer as we move forward in developing a behavioral health investment benchmark.
Go to the next slide. Good morning, everyone, and thanks, Margareta, for that introduction. So this slide you've seen before. This is the general equation that OCA uses to guide its behavioral health spending measurement. OCA's statute requires us to measure behavioral health spending, which is the numerator here, as a percentage of total medical expenses, which is the denominator. Both the numerator and the denominator have claims and non-claims components. And as you can see in the note on the slide, the numerator will include patient out-of-pocket responsibility for behavioral health services obtained through their plan, essentially those services for which a claim or encounter was generated. The denominator will include pharmacy spending and patient out-of-pocket responsibility for all services obtained through the plan. We can go to the next slide. So these are the high-level principles on which OCA's proposed method for measuring claims-based behavioral health spending is based. So first, all claims with a primary behavioral health diagnosis will be included in the measurement of behavioral health spending. In addition, claims for mental health or substance use disorder screening or assessment will be included in the measurement, regardless of whether the claim includes a primary behavioral health diagnosis. Behavioral health claims will also be categorized based on the place of service, revenue, and service codes. The categories are relevant both for reporting purposes and for identifying spending that would be included in a focused behavioral health investment benchmark, which we'll discuss in a few minutes. I'll also note here that OCA is considering applying a service code filter for claims categorized as other behavioral health services to guard against including claims where there's a primary behavioral health diagnosis, but the service is clearly not a behavioral health service. And we'll describe all these categories in a future slide. And finally, a set of national drug codes will determine whether a pharmacy claim should be included as either mental health or substance use disorder spending, independent of diagnosis. Go to the next slide. So this is a proposed process map that brings together the steps for identifying behavioral health claims. So we start in the top left blue box. The first step is to determine whether the claim includes a behavioral health diagnosis in the primary diagnosis field. If the primary diagnosis field does not contain a behavioral health diagnosis code, the claim may still be considered behavioral health if it includes a service code for mental health or substance use disorder screening or assessment. The orange box recognizes that screening for mental health and substance use disorder conditions is important for prevention and population health, regardless of the resulting diagnosis. OCA wants its measurement approach to incentivize these important services. So if one or more of those services is on the claim, then those lines of the claim are considered behavioral health. So going back up to that top blue box, if the claim includes a behavioral health diagnosis code in the primary diagnosis field, the next step is to categorize the claim by place of service, revenue, and service codes. Any claim that clears that primary diagnosis hurdle will be considered a behavioral health claim. The second step serves to categorize claims for analysis and later to determine what will be included in comparing spending to the focused benchmark. The separate flow, starting with the blue box on the right side of the slide, shows the process for identifying a pharmacy claim to be included in measurement. If the pharmacy claim includes a National Drug Code, or NDC, that OCA defines as behavioral health treatment, then the claim is a behavioral health claim. And if not, the claim is not a behavioral health claim. And lastly, I'll note that all claim spending will be categorized as either mental health or substance use disorder, depending on the primary diagnosis or NDC on the claim. We can go to the next slide. So the non-claims component of behavioral health spending measurement is a bit more complex. Measuring non-claim spending will involve a variety of methodologies for allocating some or all of a payment to behavioral health care. Similar to OCA's other non-claims payment measurements, the behavioral health measurement approach will use the expanded non-claims payments framework, which we'll look at in just a moment. The allocation methods include classifying payments for population health, behavioral health integration, and care management as behavioral health only when the payments are made to behavioral health providers. Limiting the portion that can be attributed to behavioral health care from payments for practice transformation, information technology infrastructure, and analytics. Including 100% of behavioral health capitation payments. And allocating to behavioral health care a portion of other types of capitation payments using a formula that's similar to the one adopted for allocating capitation payments to primary care. Next slide. So these next two slides show the expanded framework, which classifies non-claims payments into 6 major categories and associated subcategories. The color coding on these slides indicates the subcategories OCA is recommending should be included in behavioral healthcare spending, either in full or in part. Subcategories highlighted in green are those where OCA recommends including the entirety of the payments in measurement. Those highlighted in orange are subcategories OCA recommends including a portion of the payments. Those highlighted in blue are still under discussion with the investment and payment work group. And those that are white would not be included in behavioral health spending measurement. So you can see for categories A through C, OCA recommends including all of the payments in A2, primary care and behavioral health integration. These payments would also be included in the behavioral health and primary care module. Performance payments in category B would be included in measurement when they are paid for behavioral health services. And similarly, episode-based shared savings payments in category C would be included when the episode is related to a behavioral health condition. Next slide. For category D, capitation and full risk payments, OCA recommends including all D4 behavioral health capitation payments and including a portion of D2 professional capitation payments, D5 global capitation payments, and D6 payments to integrated comprehensive payment and delivery systems. Category E, other non-claims payments, might include payments such as retroactive denials, overpayments, payments made as a result of an audit, or other payments that cannot be categorized elsewhere. And OCA recommends limiting the allocation of these payments to behavioral health care to a fixed amount. Next slide. So earlier we looked at the behavioral health service subcategories on that process map. And this slide shows how we recommend that those subcategories be rolled up into service categories. The categories would be used for reporting and for identifying spending that would be measured against the proposed focused benchmark. So here, the community and outpatient, the outpatient and community-based category, shaded in blue, includes the service subcategories that would be part of that proposed focused benchmark. Next slide. So for the rest of our time today, I'll share some of the work we've been doing on defining the behavioral health investment benchmark. Next slide, great. So this graphic, which you've seen before, shows the distinction we're recommending between the broader approach to measuring total behavioral health spending and a more focused approach to setting a behavioral health investment benchmark. The measurement of total behavioral health spending as a percentage of total healthcare expenditures will include all the subcategories of spending. The spending counted toward the benchmark would be narrower, or a subset of all behavioral health spending, in order to promote specific policy goals. Next slide. So here we wanted to show you an example of how another state has chosen to focus its benchmark. Rhode Island is currently the only state with a behavioral health investment benchmark. Rhode Island's Office of the Health Insurance Commissioner, or OHIC, the behavioral health spending obligation there focuses on spending for community-based behavioral health care for fully insured children and adolescents aged 0 to 18 covered by commercial carriers. OHIC's spending obligation or benchmark requires carriers to increase their per member per month spending in 2025 on community-based behavioral health care for the target population to 200% of the baseline, which is based on calendar year 2022 spending data. This benchmark is not as daunting as it might sound because the targeted spending, community-based care for children and adolescents, is low relative to total healthcare spending and even relative to total behavioral health spending. For example, if this spending at the baseline were 50 cents per member per month, the benchmark would require commercial payers to increase that to $1 per member per month over 3 years. After 2025, Rhode Island carriers must maintain annual expenditures on community-based behavioral health care for the target population at the market average as determined by OHIC. This benchmark includes claims and non-claims spending for community-based behavioral health care and only applies to spending for residents of Rhode Island who receive care from providers located in the state. If carriers do not reach the benchmark, they will be subject to penalties to be determined by the commissioner. So here we see OCA's recommendation for the categories of spending to include in its behavioral health investment benchmark. We will be presenting this recommendation to the investment and payment work group when we meet with them later this week. They have not yet reviewed or commented on this specific recommendation. The proposed benchmark would include claims-based payments in the outpatient and community-based services category, including mobile clinic services, outpatient professional services, and outpatient facility services. In addition, the benchmark would include several categories of non-claims payments, to the extent those payments are allocated to behavioral health care using the methods I described earlier. Population health and practice infrastructure payments and performance payments for behavioral health would be included. A portion of capitation payments would be included, representing encounters for services in the outpatient and community-based services claims category. Next slide. So as with the primary care workstream, there are some key decisions OCA will consider in developing a recommendation for a behavioral health investment benchmark. We'll look at each key decision individually in the upcoming slides. And those key decisions are: should the benchmark be a percentage of total medical expenses or a per member per month amount? Should the benchmark focus on incremental or long-term improvement, or on some combination of the two? And finally, what should be the timeline for achieving the benchmark? I want to note that as with the categories to be included in the proposed benchmark, these key decisions will be discussed with the investment and payment work group at its meeting later this week. Due to the timing of these groups' meetings relative to each other this month, we wanted to be sure to take this opportunity to get your input on these key decisions today. So on this slide, we see that starting with the first decision, a benchmark could encourage payers to increase threshold measured as a percentage of total medical expenses, or TME, or it could frame the benchmark as a per member per month amount. Supporting the TME approach, OCA's statutory mandate suggests this preference. In addition, setting the benchmark based on TME communicates that increased spending on behavioral health care should reallocate the healthcare spending pie rather than lead to an increase in total spending. This approach is also consistent with OCA's approach to the primary care investment benchmark. One reason we may want to consider a per member per month approach is that it might better reflect the cost of achieving behavioral health care delivery goals. It can guard against the benchmark becoming unnecessarily inflationary if total medical expense increases are higher than expected. And the per member per month approach is more consistent with how payers typically measure health costs. You also may recall that Rhode Island based its benchmark on a change in per member per month spending. On the next slide, we have our next question, which is, should OCA set an annual or biannual improvement benchmark, which specifies the incremental improvement each payer should make over a series of short time periods? Or should the benchmark focus more on a statewide goal achieved over a longer time horizon? Or should it be a combination of these two concepts? Annual improvement and long-term investment goals offer different benefits to benchmarking. An annual improvement benchmark meets each payer where they are today and recognizes differences across payers and patient populations. It also allows for short-term adjustments as actual spending levels become clearer with submission of data in early years. In contrast, the long-term investment benchmark offers a vision for the future across all payers. It can also reflect current thinking about the right level of spending, as well as the long-term infrastructure needed to reach the benchmark and the budget needed for that infrastructure. A combination of the two approaches would capture the benefits of both and parallel the structure of the primary care investment benchmark. Next slide. So our final key decision is regarding timeline. And some considerations to discuss for this are, first, OCA believes the benchmark should be aggressive in pursuit of the underlying policy goals, and at the same time, it should reflect reasonable expectations of how long it will take to achieve. We may also want to align the benchmark timeline with OCA's other adopted benchmarks. the spending growth target set for 2029, and the primary care investment and alternative payment model adoption goals for 2034. Next slide. So in this slide, we can provide some context for considering an appropriate timeline for the behavioral health benchmark by showing you OCA's other benchmarks. So as a reminder, OCA has adopted an overall spending growth target that starts this year at 3.5% and tapers down to reach 3.0% by 2029. In parallel with the future behavioral health investment benchmark, payers will also be working towards alternative payment model adoption and primary care investment goals. The APM and primary care benchmarks combine incremental and long-term goals, with 2034 as the timeline for achieving those longer-term goals. The benchmarks acknowledge payers' different starting points and capacity for short-term improvement, and they allow for adjustment as the picture of current spending becomes clearer with more data. The long-term perspective of the benchmarks allows OCA to set a longer-term vision aligned with state policy goals. Next slide. And so before we move into our discussion, I'll just finish with a reminder of our tentative timeline for the behavioral health work. We updated the board on the behavioral health workstream last month, and we'll be meeting with the work group this week and then monthly through July. Our timeline is extended by 2 months from our original timeline to allow more time for OCA to gain feedback from stakeholders as it develops its recommendations, and also for the advisory committee and the board to consider those recommendations during the spring and summer. OCA plans to bring a recommended behavioral health investment benchmark to the board for approval in July. We'll provide interim updates and gather feedback from you again in June and from the board at both their April and June meetings. Next slide. And last slide. So now we'll open up for some discussion. We are very interested in your feedback on what we've presented today regarding the proposed categories and subcategories for measuring behavioral health spending and the proposed methods for allocating non-claims payments to behavioral health. We're also interested to hear your thoughts about the trade-offs on the key decisions for setting the behavioral health investment benchmark. Go ahead, Andrew.
Yeah, so I guess I have a few comments on this topic. The first thing is really around behavioral health and primary care. So I don't know if the team has had a chance to look at the data where, you know, there's a behavioral health diagnosis, but it's in it's secondary, it's not primary. It's one of those things where do we know how much we're actually excluding here? And, you know, if you think about, again, back to incentives, right? So, you know, what are we really incenting? And also, do we even have the provider supply on the behavioral health side? So I think there's, you know, you have to think through, you know, just behavioral health and primary care. And I don't know how much we're excluding. Maybe the team has actually done some work. The other thing is behavioral health is such a continuum across kind of the sites of service. I just worry about excluding some types of services like inpatient, right? We will probably, it's a value judgment of what is kind of effective versus not effective. I'm looking at it as, does this mean there will be under investment in the stuff that we exclude? So that's kind of just a general worry, right? I mean, do we have enough inpatient psych beds? I mean, are we overbedded here that, you know, we kind of want to create a disincentive that way? And then the other thing I guess I would say is, you know, this is a measurement on spending. How about quality, right? It's you know, what are we, you know, kind of just the job to be done isn't to spend more money, right? It's to actually achieve an outcome for people. So I guess that's the one piece that I don't know that we've actually looked at.
Sure. So I think we can start with, in terms of behavioral health and primary care, we are very actively aiming to measure behavioral health occurring in a primary care setting through a behavioral health and primary care module. I think the challenge that we've been discussing in the work group in terms of using primary diagnosis to identify behavioral health spending is that if we include secondary diagnosis, then we potentially capture a lot more spending that's not directly for behavioral health services, and could greatly expand our kind of capture of spending. So thinking about primary diagnosis, the reason we're proposing to focus there is to look at those services that are directly related and provided in service of a behavioral health diagnosis. And also we could think about potentially using the HPD or other data sources to understand how much information we're missing when we don't use secondary diagnosis. So that is the reason for the focus, is that challenge that we've talked about, I think, in primary care as well, of the balance between overcounting and undercounting for behavioral health.
Yeah, I guess let's see what the work group is thinking. But to me, it's just like, it's always about whole person care, right? It's kind of, it's hard to, you see a patient, they have physical and mental needs, it's like unmaking soup, I don't know. It's really what incentives are we creating? Oh, I have one more comment on the PMPM versus percentage. I'm probably closer on the PMPM cap, because if you look at the big drivers of increases going forward, pharma is huge, right? You're talking cell and gene, you're talking about all these other things that are coming down the pipeline. You probably don't want that as part of your denominator, but that's kind of one man's perspective.
Andrew, I also just wanted to appreciate the comments about the infrastructure and the workforce. So, I mean, this, the state's very aware of that. That's why there's the Behavioral Health Services Act and the passage of Prop 1. And so I think Margaret and Debbie have at other times kind of given that additional context. So we're very much tracking the need for more infrastructure, and assuming there aren't changes made, we have very significant Medicaid funds coming in to assist with behavioral health workforce development.
Great. We've got Janice, Marielle, Sumana, Stacy, Joan, and then Parker.
Yeah, thanks. Just a question. How long has Rhode Island been tracking behavioral health?
I don't know the exact number of years they've been tracking, but their benchmark is for comparing this year's spending with the 2022 baseline. So we can come back with more information about exactly how long they've been tracking it.
Yeah, I'm just curious what we could glean from what Rhode Island has already done in terms of, investments and how it's improved outcomes.
We can follow up on that, but their benchmark does not become applicable until 2025 or, applicable this year. So I'm not sure if they'll have outcomes yet, but we can certainly follow up to discuss, how they landed on their benchmark and what the intent behind it is.
Thank you, Marielle.
Hi, first I want to thank you for this really detailed, thorough presentation. I think you did a really great job putting all of this together. It's obvious that a lot of our, comments and concerns have made it here. I do have a few questions and a few comments. So, I do agree with my colleagues in that I am concerned with really the way that we're thinking about behavioral health as part of everyday health, right? Not just when I need services. It's part of how we just live, and behavioral health is moving in that direction. And I worry that if we get too caught up in categories, and again, I don't know the answer to that, but I'm just posing a concern. I worry that we're going to not only move backwards from some of the work that a lot of advocates and healthcare providers, including behavioral health providers, have tried to do to move our delivery and quality and access to behavioral health services forward. But I think that it may also stifle us in some regards. So I don't know what the answer to that is, but I'm just echoing that concern. And when we think about, well, when do you go seek behavioral health care? The truth is most people won't. most people who need it or who could really benefit from behavioral health services, whether that's a mental health condition or a substance use disorder or anything substance misuse related, they're not going to seek those services. And so, again, I worry that if we spend so much time looking at the clinical pieces, which are undoubtedly important, right, we may be missing those folks that are in between. And the truth is, most people only seek services when they are in, they're hitting rock bottom. And we miss all of those folks that we could have done some early intervention from. So a lot of that early intervention tends to come from a lot of community work. And, yes, I do represent a community-based organization, but your access to faith-based organizations and so forth and other types of those groups and affiliations. But, I worry as we're moving into a really difficult economic financial period, and this period is already difficult for so many of us, right? People are going to do worse, right? And I'm again, I worry that we're kind of leaving so much room for what people need. And I know this only complicates things, but when I think about behavioral health, people are looking for belonging, for connection. I don't think that it necessarily happens in the clinic or in any kind of outpatient setting. It can happen, but the way that we're going with the shortage in healthcare providers, and now we want more people to go seek services, which is great. That's wonderful. We should have that available to them, but we're not going to have that workforce to support it. And the thing is, in order to deliver like really quality behavioral health care and even to be able to establish that kind of rapport and relationship, like that takes time. And we only have so many hours in the day, so either we're adding more to our current shortage, right, more workload to our current shortage of behavioral health providers, or can we think of it differently? That's kind of where I'll leave my question. I have so many other things to say, but I think this is already a big one, right? Like, can we really reframe, right, how we're talking and thinking about this? Because again, I worry we missed the boat. And I can talk about the California Reducing Disparities Project and community derived evidence-based practices later, but I'm just going to pose that question for the board, the committee, and everyone who is also here presenting. Thank you.
Sure. So I think where I would start is potentially with our limitations of data collection, which is, of course, a challenge that gets exactly to what you're speaking to of how do we capture more broadly the prevention and early intervention work that's going on outside of the clinical behavioral health space. And I'll just note with our data collection, we are collecting data from health plans, from payers. So that is our lens of how we're looking at behavioral health and how we're defining behavioral health. And I think, the important points you raise about, community-based services and community-based interventions, and that those types of services are spending we could either look to capture more broadly in the future, or we could look to capture, report on that spending and how that complements the spending by health plans on behavioral health services. So it is a limitation of our data collection that we are aware of, and open to suggestions for how we might, more comprehensively capture behavioral health spending. But our focus for the benchmark is, how much the healthcare delivery system, how much payers are spending on behavioral health services. So capturing that spending and where do we want to invest more or reallocate dollars to?
Thank you. I've got Simona, Stacy, Joan, Parker, and Suzanne.
Thank you. This task force's purview is so complex, given that it's new territory. And I just wanted to note that the non-claim side that people have talked about so much, recognizing that that's going to be very difficult to measure. It's just a thing taken on faith. We don't know for sure, but as payments for services through plans improve, it will be good to see that, we're going to assume that that side of it really comes down. Credentialing and paying more to individual therapists. Yes, there's a workforce shortage, but there's a lot of young people who are very interested in this field. And so I'm feeling really positive that as reimbursements improve and support for therapists improve, that the pipeline here will get better. I see that in my population all the time, particularly the bilingual, young people who really care to do this. I've shared the difficulty we've seen with plans being really reluctant to credential despite notable shortages. And that currently, and I'm hoping this will be a short-term phase, that companies that are able to get around this with sort of bulk credentialing or whatever the term might be are working around it and almost locking in new therapists, which is definitely a concern to track. Integrating with primary care is the goal that I know you all share with me. And I think keeping the payment side measurements separate still makes sense, because this is the world where people who are suffering in a whole body way, emotional and physical, and get that care, we will start paying more attention to how to integrate that care. And we're going to see, I believe, tremendous cost efficiencies from doing that, because so many of our patients who end up in emergency rooms dealing with anxiety and such, if we can really integrate and talk across primary care and behavioral health, that's my dream. And I know that this is going to get us there.
Thank you. Stacy?
Well, kudos to coming up with the proposal, because mental health is probably one of the more complicated areas. It's a carve out in our HMO capitation. So, and we don't have behavioral health providers that we're billing for. So all of our primary care physicians that are providing mental health services, a lot of those claims get denied by the payer. So those aren't being captured, or the EAP services that the employer provides. Those are another gap, but that's a known issue and may be different based on each individual employer and payer. Is the intent to be measured at the health plan level, payer level, or is the intent to roll that down to providers?
Our intent is starting with payers at the health plan level.
So if your intent in the future is to roll it down to, provider groups, the health plans will have to attribute those services to medical groups or individual providers, which would get very complex. So just, how the flow funds is something to be cautious of. And then just the PM versus percentage. Sorry, Vishal. Usually on PPO, it's a subscriber level versus a member level. So I don't know how you would do that on PPO unless things have changed. On the PPO side, on HMO, you have a per member number, but usually on PPO, it's per subscriber. So how would that compare and roll up as one area? And I also agree with Andrew's comments about excluding inpatient. I think you need to look at the holistic view of behavioral health because it's complex.
Yeah, thanks, Stacy. I was going to just address your question about provider level data. It is something we're interested in. We want to start with payers first and kind of get that bird's eye view. And then we do have some requirements in the law about capturing data, APM and primary care data from RKKs and limited Knox-Keene Act licensees. So those are restricted Knox-Keene Act licensees. So those are the entities that are taking global risk from health plans, and so we would be able to measure the extent to which they're engaging in APMs and primary care. So we think that could be a launching pad for seeing what kind of data we get from providers, and then potentially doing direct collection from physician organizations. We think they'd be the best. It'd be better to just go to the source rather than have the payers,
Right.
Attribute it.
Right.
Yeah.
So the RQKs, I think for commercial plans, that behavioral health is carved out completely, even
Yeah,
from the RQK. So it's a complicated one. Granted. Thank you.
Joan?
So behavioral health is one of the spaces where we have seen pushing the boundaries of telemedicine, whether it is sort of very straightforward, an office visit that is happening via Zoom or the phone rather than in person, to chat-based behavioral health, to very AI driven. And that we've seen a huge spike in that. Yes, some of it's happening on the EAPs outside the plan spend, but I'm definitely seeing that also happening inside the plan spend. And it's mostly just a note of caution that when we are setting targets, whether it's PMPM or whether it's percentage, I do worry that creates a window for some of those tech companies to see a place where we actually are encouraging more spending, and would want real oversight over whether those should actually count, particularly the ones that have less clinical interaction, the chat-based, the more AI-driven, and would worry about those being counted. I will admit I don't know the HCP land categories well enough to know where those lines are, or whether HCP land has caught up with the technology that is moving very quickly. So any thought so far along the lines of those new technologies?
So I think generally in the expanded non-claims payments framework, that spend that supports IT infrastructure or anything related to like supporting providers to expand their IT infrastructure, whether that means maybe using some type of behavioral health AI, would be captured in our category A. Right. If I remember correctly, in those associated subcategories, and then other spending that's can't be, and I don't think it would be categorized nicely elsewhere across the expanded framework, would be captured in our other spending category. So, and for both of those categories, we are proposing to set a limit about how much of spend in those categories can count towards the behavioral health investment benchmark.
Thank you. Parker?
Thanks for this discussion. And in a way, I think that our actuary, Andrew, probably gave the best summary of what I'm going to say, which is whole person care as a primary care doc. And granted, my perspective right now comes from working at FQHC, so we're 90% Medi-Cal essentially funded. I know you're considering embracing that, but the point is the same, that for us, and right now this is our insurance gaming system. I always tell my residents that there's no visit that does not include behavioral health. So if I'm doing a weight loss visit, that's behavioral health. I might still code it primary as just their BMI so that I can qualify to get them the medication they need. One of the other ways we work our reimbursement within our Medi-Cal is, of course, we have, and it's a pretty common thing in FQHCs, we have what's called the warm handoff model. So the issue is really a behavioral health or mental health issue, but I place a not false, but true diagnosis, so weight loss, but the patient's just really struggling with depression and whatnot and can't get in to really see somebody. So they see me, I do a very brief medical visit and I walk out and then our behavioral health person comes in. So it's essentially a shared visit, and that would be very difficult to tease apart whether you're saying use a primary or secondary code. And that could be extended. That's weight loss, that's postpartum depression, that's early pregnancy loss, miscarriage visits. That's such a broad spectrum of covering visits that we see in primary care. The punchline to me is, from a primary perspective, as long as this is a yes and equation, so increase primary care to 15% and come up with a behavioral health that is essentially additive to the world of behavioral to primary care, then this is a double win to me from a primary care, because that's the goal. And whether we need to tease that out, but that would be my plug here. As long as this eventually is becoming an add-on win-win or yes and situation, then this is great stuff, and appreciate your work.
Thank you for that. I just want to come back to our behavioral health and primary care module, which we didn't discuss here today, but I think we might have mentioned it last time we were here. And we are definitely endeavoring to capture that the behavioral health that's occurring in the primary care setting and incentivize that by measuring that separately and being able to calculate the total of between primary care and behavioral health without double counting that really important core piece of the behavioral health that happens in primary care. Thank you.
Thank you. We've got Suzanne, Marielle, Adam, and Carmen.
Thank you. That actually is a perfect order, because I'm just going to say I completely agree with what Parker just mentioned. I was mostly going to refer to the subcategories, but it warrants talking about the fact, like, the only reason I believe that focusing on the outpatient, community outpatient, the existing categories that have been identified, is because of the fact that there is the 15% total medical expense target for primary care, and because you guys have mentioned that you're focusing on primary care, because I think we've said ad nauseum, which warrants repeating over and over again, that behavioral health is not just one point in time. So if we've all decided, not just as an advisory committee, but OHCA, HCI, and state of California can go on as high or as low as you want to go, that the investment in preventive care, investment in keeping people healthy, as opposed to just improving our healthcare facilities, is the important part, then I think we're already going the right direction with the primary care spending target. So the categories of, sorry, I moved it, but I think it was all the outpatient ones that talked about being community outpatient and whatnot, kind of goes along that same line. If you do have someone that is higher acuity or higher severity, then having them in an outpatient facility and not just with primary care would be valuable. So if you're already increasing primary care, then I think measuring increasing outpatient care would, for this specific area for behavioral health, I think would help. And then I'll echo the ideas. I think Andrew and Stacy both mentioned the idea of moving more towards, maybe it's SPM for subscriber. I always say per employee, but per the subscriber, per the individual, or if it's per member, I think that might be a little bit better, because then if you're already looking at increasing the primary care as being the crux of like where all the meat is, then there's also not this noise of other high costs that go up that are completely unrelated, or maybe related to behavioral health, but not, maybe shouldn't affect the cost of behavioral health. Then I think we're marching towards trying to make sure we're spending in the right area. So if that outpatient community is going up a bit and primary care is a bigger percentage, then we've kind of taken those patients and individuals out of those settings that maybe is not as appropriate for those people. So those, I think, were generally the thoughts. I think the categories are correct from my perspective, and looking at something that's not a percentage and more of a per member or per subscriber cost might be more appropriate.
Thank you, Suzanne. Marielle.
Thank you. I didn't get to mention, I do prefer the member per member. I think that that'll give us much more helpful data as all of these behavioral health systems changes are rolling out. I do want to return to, again, the idea that having providers is what's going to get people in talking about behavioral health. And that's just not factually true. Stigma is a big part of why people don't go to seek these services specifically, right? So this is a cultural issue, right? But it's also a cultural issue in a sense that not everybody, right? And these are various cultures, right? We live in such a diverse state, and we're so gifted with so much like cultural richness, right? But not every culture identifies like this behavior as, okay, this is what I'm going to do to address that, or it's specifically like a mental health or substance, some kind of codable diagnosis or at least service. And so again, we're talking a lot about whole health, which is great, but I think that we're getting so granular in the data that we're missing the forest for the trees. So again, when we're thinking about like, how are we allocating funds? How are we actually thinking about it? I really urge us to think beyond, okay, well, if this happens, then that, when we know for behavioral health, right? We don't really know when people step in. And again, it's not, people aren't going to need necessarily more services, and they're not going to go seek more services because there are more providers. They will seek more services because they are going to have a hard time. And we see that happening now. So I think we're going to be conflating, right, data from people who there's more people going in through the door because the conditions are getting worse versus people are going because there are more providers, and correlation is not causation, right? And I think we need to be able to tease that out. I think this is like a much longer conversation, obviously, but I would really be interested in being part of that and discussing this aspect further with everyone else.
Thanks very much, Mariella. And I just want to appreciate the conversation that we're having about, aspirationally, what do we want our healthcare system to look like? And that's absolutely what we should be doing. And we always start there, and the team starts there. I know that's what drives Debbie and Margaret and all of us. And then we have to get at some point nitty gritty about the implementation. So we share the vision, and we also have to operationalize it. So thank you for continuing to remind us of the big vision and help us think through the details and how to actually develop a measurement methodology.
Yeah, and I appreciate that. I understand that we're trying to better gauge these systems through data, but are there other ways that we could be thinking about this in addition to data, right? Because I think that when we're limiting it the way that we are going to be measuring, we're not capturing an accurate picture. So even then, all of these efforts, and for what, there's still big pieces that we're missing. So I'm not saying let's not do this. I'm saying, what else can we do to support this? Because in my point of view, this will not be sufficient. Although it will be important and great, I think there's much more data that we're going to lose as well. So that's my concern. I'm not saying let's not do this, but I think it's not enough.
Yeah, Marielle, absolutely. And I appreciate all of your feedback. And I think, this is a parallel effort with many other efforts that the state is engaging in, from the Children and Youth Behavioral Health Initiative, your important point that different cultures may access supports services in different ways, and we need to be aware of that. Lots of initiatives at the Medi-Cal side, lots of work that DMHC is doing with health plans. So agree with you on the big picture, and this really is a parallel effort with a lot of other work.
Thank you, Adam, and then Carmen.
Yeah, just thinking about that. I mean, the conversations are fruitful. I think that's the value of this advisory committee, is bringing together those different perspectives and viewpoints while understanding the extreme limitations that you guys are under, whether it's statute or resources or what have you. We're not going to solve the California healthcare crisis at this table today or anytime soon. So I think focusing on you know, measurable impact, triaging the highest, you know, highest need, highest value, biggest gaps that we can while keeping that pie in the sky. But, you know, looking at the data specifically and thinking about how we are, you know, we're all speaking the same language, but we have to be able to use the levers we have in this room through your statute to tackle those in a very narrow way. And that's why I think we have to use the data. We have to come down to this because it's really kind of all we have. I mean, I think also a value are our anecdotes. I really appreciate Parker's, you know, introspective into how we as clinicians game the system a little bit, how insurers game the system to avoid certain things. You know, my chest pain patient in the ER, it's actually, you know, an anxiety attack, and maybe they're having an anxiety attack because they're withdrawing from opiates. So maybe the substance use navigator that I consult to have them come and start, you know, medication assisted therapy is really, you know, obviously from the patient's point of view, the main impact there, but from the payment point of view, that would be lost. And then of course, you know, from my perspective, my anecdote as well is, you know, once they get to the ER, it's kind of the system has failed. So whether it's the revolving door of, you know, incarceration and my ER and a treatment center or at home, where I think that, you know, that hot potato that gets passed around can be manipulated. So I don't know how we could include things like the correctional services into this as well, whether it's the health profession database or, you know, I don't know if it would necessarily fit under one of those subcategories, but by passing the buck on that, that clearly has implications, and, you know, being able to look at some of that longitudinal theme that we're thinking about while doing everything we can with my one encounter in the ER, I think is helpful as well and impactful. We can provide, you know, brief interventional services that can have measurable impact as well. So again, thinking about those incentives and where plans may not feel, you know, conducive or incentivized to do those need to be highlighted through this effort.
Thank you, Carmen, and then Hector.
Yeah, I want to thank you all for the work on this. I had a little bit of a technical question that might help kind of pull together some of the discussion about, you know, what counts towards the non-claims behavioral health. I saw on page 80, it refers to non-claims as, you know, claims only when paid to behavioral health providers. And I was wondering if there was thinking behind that, because then when non-claims payments are disaggregated under A, there's, you know, you have A2, which refers to behavioral health and behavioral health integration. So that in theory would be capturing some of the things that Adam and Parker are covering. But like, what does that mean to be a behavioral health provider? What if a primary care clinician like Parker gives, you know, when will it count and not towards the investment benchmark? And then secondly, kind of, you know, towards what Adam was talking about is I know that there's a larger total behavioral health expenditure and then there's investment. I mean, it sounds like what a lot of us want to see is like what happens if we have an investment benchmark, and then how does that impact, you know, ED visits or other types of you know, inpatient psych visits, and is there, you know, we over the long term we want to see where the investments are going. So like maybe that goes towards TME or total medical expenditure type of analysis of the investment benchmark. But I guess those are questions that would help understand, you know, where we're looking at and how we're trying to understand who is actually providing the care, because we don't, you know, we don't want to disincentivize primary care physicians or from investing in behavioral health, you know, care. And then I just wanted to, you know, underscore and emphasize Joan's comments on AI and investments. And I think there's a really strong consideration here that any EHR or information technology investment should not include any AI part that is particularly, untested or unverified, because we know that there's a lot of issues with validation when, whether it's a small physician medical group or a large healthcare system adopting AI right now. And I think it's perhaps goes to the question about what is a behavioral health provider providing this care, because AI that doesn't have, a healthcare provider backing it up shouldn't be counted towards the behavioral health investment benchmarks. Thanks. So I think, sorry, if we could go 2 more slides advanced. There we go. Thank you. So just in terms of the non-claims payments, and Debbie, please add here. So broadly, OCA is capturing all non-claims payments through our total healthcare expenditure data collection. We have proposed an allocation methodology that we're implementing an allocation methodology for how much non-claims count towards primary care. And then we also are implementing a methodology for how much non-claims counts towards behavioral health. And the intention is that those, the primary care non-claims and the behavioral health non-claims, the allocation methodologies are similar, but they're measured distinctly and they do not overlap. So it is how much non-claims is going towards behavioral health spending, how much non-claims is going towards primary care. And then additionally, we also have our behavioral health and primary care module. So to measure kind of what is the overlap between behavioral health and primary care, kind of measuring that overlap of behavioral health services occurring in a primary care setting. So on those previous few slides of the non-claims allocation, we are proposing that in order to count towards behavioral health spending, that a non-claims payments needs to be to a behavioral health provider or to a behavioral health organization to count as behavioral health spending. So separately, we have that same approach for primary care, and then broadly, we're through THC measuring total non-claims payments. So only the portion of non-claims that are paid to a behavioral health organization or to a behavioral health provider count as behavioral health spending. And then, do you want to add anything, Debbie? Or do we have a definition of behavioral health provider? Yes. Okay. Just making sure. Because we are working through that with the investment and payment work group, but essentially defining a set of providers that count as behavioral health providers. Yes. And sorry, Carmen, did you have another question or anything else that would be helpful to expand on there? No, that was helpful, because I didn't know if just kind of to put this to the test a little bit. So for A2, primary care and behavioral health integration, that would have to be a non-claims payment paid by either a behavioral health provider or a behavioral health organization, even though we're talking about primary care and behavioral health integration. Is that correct? So that specific, it would be paid to a behavioral health provider or behavioral health organization, yes, but that specific line item would count in our behavioral health and primary care module. Sorry, there's a lot of pieces to put together, so we appreciate you all working through this with us.
So we've got Hector, and then I think we will wrap up this item.
Thank you. Echo what's been said earlier. I think, I prefer and I would support the PMPM model for the reasons mentioned. Plus, so much of our environment in California is HMO capitation. In the delegated model, the IPAs can actually be very helpful in tracking that PMPM payment. And as we're starting to see on the PPO products, the health plans will keep medical cost ratios on their premium, and one of the line items will be behavioral health. So I think there's an opportunity to capture that data there. And in that regard, I wanted to recommend, if you haven't already reached out to the Integrated Healthcare Association, to Jeff Rideout, one of the projects we're working on is the EDGE program, the Encounter Data Governance Entity, which will allow us to start looking at how well does the encounter data capture all the essential diagnoses. So even if the primary is, as Parker was saying, is overweight management, that the behavioral component of that is added. There's always a workforce issue that goes with this. I'm a family physician, like Parker and others, is that family medicine requires behavioral health training in the residency program. It's a competency that no one can graduate if they don't demonstrate proficiency. And it's really what helps us just automatically address that issue. As Parker was saying, everybody comes in, either if the issue today is not a behavioral health issue, over the time that we take care of that patient, things will show up. And now that we're doing ACEs screenings, even more prevalent. But the key thing is looking at how we influence workforce training so that other specialties adopt the same kind of requirement. But tracking the data along with the PMPM model will be assisted by the MCO tax. If we get it off the ground, the targeted rate increases. All these codes include behavioral health services provided by a primary care clinician. And the advanced primary care model, which focuses on commercial patients right now, starting with PPOs, but CalPERS would like HMOs to be included. It'll give us an opportunity to track those different codes, and engaging IHA on the Encounter Data project, I think should be able to unify all of this for us. The other piece here that might be worthwhile, I would recommend inviting Dr. Leo Lopez, who's the CMO at Whittier Presbyterian Health System. When he was with Med Partners in Long Beach area years ago, they actually adopted an open access to behavioral health model because they knew that many times patients were showing up to the emergency room as a cry for help, or self-medicating with drugs or alcohol or other substances as a cry for help, that if they offered open access to behavioral health, they would actually be able to reduce costs. And they were able to demonstrate that. What they could not sustain was that they couldn't find the workforce to meet the needs of their population, because once patients heard about that open access to behavioral health, they actually started to utilize it. It'd be great to hear their experience in that regard. But in terms of tracking data, PMPM makes sense. In terms of the data that we can collect, the targeted rate increases in the APC model will help us identify those codes, and inviting IHA to track all of that would be really helpful. So thank you.
Thank you. I think that concludes discussion on this item. We'll now move to public comment. We'll start with the individual at the podium. Yeah, the button with the face on it until the light turns red.
There. Can you hear me? Thanks. All right. Need my glasses here. Carrie Sanders with CPEN. Appreciate the conversation. Communities of color are disproportionately overrepresented in inpatient psychiatric care, while their access to preventative and early intervention services is inadequate. So we, agree with the other speakers that there are several underlying costs for this. Underlying reasons for this cost: lack of culturally and linguistically appropriate care, stigma, other concerns that lead communities to delay necessary preventative care until conditions become worse. The end result is that, consumers are paying 15% of all mental health spending nationally is paid out of pocket by individuals. Individuals in the commercial market are 6 times more likely to go out of network for care. And 1/3 of these cases, they bear the full cost themselves. So it is an equity issue, and it's not just an equity issue. It's also a spending inefficiency that could be better addressed through better network adequacy and targeted investments. And for this reason, we strongly appreciate and support OCA's behavioral health spending approach, which redirects behavioral health spending towards community-based prevention and early intervention programs that reduce the need for high cost intensive services later. Specifically, the expanded framework and inclusion of outpatient CBO service claims, population health, and practice infrastructure payments, which can include services provided by individuals with lived experience, and like peer support specialists, community health workers. We also appreciate the important discussions that are happening right now in our work group on how to appropriately measure behavioral health integration in primary care, and appreciated the comments from Parker and Hector earlier. The real goal is to encourage greater alignment between primary care and behavioral health and not have such a delineation. We want a whole person approach. That is a win-win for consumers, and I think we can get there. As for the specifics of PMPM, et cetera, we also support generally alignment of OCA's approach here with its approach to primary care. Thanks.
Thank you. Looking virtually, seeing no hands raised, noting we have about 67 virtual attendees, we'll go back to the podium.
Beth Capel with Health Access California. Part of the vision behind the Office of Healthcare Affordability, including behavioral health, was exactly to have the kind of conversation you're all having today and to try and get to a benchmark that moves us to a better place. I want to agree with what Adam said, that when somebody shows up in the emergency room, it's in a sense a failure of the system, just as when a kid who has asthma or someone with diabetes whose care could have been managed in an outpatient setting shows up in an emergency room, or even worse, in jail. People who need the emergency room, people who need the hospital should have it. Let us be clear, but people should not be ending up there because that's the only way they can get care. So that's part of the vision behind the benchmark that you're seeing, which is not to say we're going to eliminate hospital care, but to say we need to move to getting people in network care. And I want to emphasize, because I think this is one of the things you have not discussed today, as Carrie just from CPEN just said, how much behavioral health is occurring out of network on the consumer's dime instead of being covered. For almost all of the long career I've had doing healthcare, more than 40 years now, too often, behavioral health has been treated as, at best, an orphan child and something that was unnecessary and unimportant. The reason we included it in the OCA law is because we recognize how important it is to health and that we can no longer treat it as a stepchild. What we have is the result of those decades of prejudice, misallocating resources and misallocating workforce. And so that's why you have this task before you. It's not an easy one, and I don't envy you, but it's really important. Thank you.
Thank you. Continuing public comment, please step to the podium, or if you're online, raise your hand. If you're dialing in, press *5. Seeing no further public comment at this time, that concludes this agenda item and takes us to break.
We're going to take the full hour for lunch. So folks, if we could reconvene at 1:15, and we'll look forward to hearing from Altamed and then discussing the equity and quality measures. Thank you.
Good afternoon, everyone. Welcome back from lunch. Again, Margaretta Brandt, I'm the Assistant Deputy Director for Health System Performance at OCA, and today are excited to share with you a cost reducing strategies presentation from Altamed. And before I introduce Altamed, I just want to remind everyone that OCA is seeking additional examples of cost reducing strategies, and these examples might include a program that addresses a specific population, implementation of best practices for more efficient resource use, or an effort to increase coordination to improve costs and to reduce costs and improve quality. And the details of what we are looking for are on the slide here. And if someone is interested in proposing a cost reducing strategy to OCA, you can email a proposal to our general inbox, and we'll follow up with you to learn more. So with that, I would like to go ahead and introduce Dr. Talamantes, the Senior Vice President and Chief Operating Officer of Health Services at Altamed, to share their cost reducing strategies with the advisory committee.
It's red now. Thank you so much for that introduction, and good afternoon, everyone. I'll set a timer to make sure we stay on track here. First of all, I just want to thank everyone for rescheduling this. I know I was supposed to come here earlier in the year. And like many of you, we had our own fires to deal with and actually lost one of our clinics. So we really had to pivot around the needs of our community and some of our workforce as well. I'll share a little bit about that in a moment. If we go to the next slide, please. So today I'll share a little bit about our history, vision, mission, values, more importantly, our strategy as to how we were invited to this talk today in terms of some of the value-based care outcomes that we have really taken a lot of courage and been bold to try to achieve. I'll share that as part of our journey in terms of a couple of examples of actual programs like our Viva Gold Senior Care Program, our Enhanced Care Management Program, as well as workforce and pipeline efforts to support this great work. And then some next steps, more importantly, I think, given the current climate, some of the challenges and opportunities that we're facing. We'll go to the next slide. So Altamed, we were founded as a storefront volunteer staff clinic in East LA. Today, we're the largest independent, federally qualified community health center in the United States. To the left of you here is obviously an old photo, and then to the right is one of our newer sites. Again, state-of-the-art, beautiful clinics that we're able to offer our community and our staff. We'll go to the next slide. Our mission really focuses on eliminating health disparities, not only in access, but also outcomes. And again, really pushing ourselves to do this through a world-class, world-integrated delivery system, or integrated world-class service delivery system for Latino, multi-ethnic, and underserved communities in Southern California. And a lot of this is really based on our CEO's call to action. He's obviously been at Altamed for many, many years now, and really always asking us as his leadership team to really step up and make sure that we're the leading community-based provider of quality healthcare and human services. I was just sharing with some of the folks here earlier around, we just finished our 5-year strategy. And by 2030, we seek to not only be 90th percentile in many of the measures in terms of quality population health, but also achieving a 4.5-star rating in Medicare benchmarks, as well as growing to 500,000 full risk members or patients within Southern California. And we'll go to the next slide. Part of where we've been, obviously, I've been at Altamed for 7 years now. We've almost doubled in size. So when I first started, we were about 2,000 or so employees and staff. Now we're close to 5,200. We've, again, grown through buying independent practices or acquiring other FQHCs. We currently have 67 sites in Southern California, both LA, Orange County. And we span all the way from like Pasadena or Altadena all the way down to the Santa Ana in Orange County. We're serving about 500,000 patients annually. Last year, we had a little under 2.9 million clinic and or virtual visits. And, you know, the patients we serve, heavily underserved, obviously, mostly Medi-Cal, 84% Medi-Cal, 74% identify as Latino or Hispanic, and 40% speak another language other than English. And again, you know, very high social vulnerability or housing stability. There's a lot of instability in housing as well. So a very underserved community. And that's just a map of all our different sites and where we're currently located. But go to the next slide. You know, it's been a real journey for me personally. I'm an internal medicine physician to come to Altamed and really think through the challenges of patient care, not only from the perspective of underserved communities, but knowing that we have an aging population, so seniors, really looking at the challenges that adults face, especially those that have higher social and clinical complexity, as well as our women, our children, and then, of course, growing needs We have a very robust musculoskeletal program given a lot of the chronic pain issues that we have. And so being able to evolve our model to really having specialized programs to focus on these populations and also some of the unique needs. But we also offer not only medical care, we also offer dental care, behavioral health care. We have our own pharmacies as well. And then we have other on-site, like I said, specialties that go beyond MSK or sports medicine. We do have a very special relationship or partnership with the Children's Hospital Los Angeles. And so we have a lot of our pediatric specialists from the CHLA. We also have invested heavily in developing our own Institute for Health Equity, which has a research department as well as a medical education department. That's where we house a lot of our pipeline and workforce training as well. And we're also known as one of the nonprofits that has one of the largest programs for all-inclusive care, which is PACE. And that is a fully capitated program, one of our programs that we've learned a lot from and really pulled from those lessons into primary care to figure out how to not only deliver high quality care, but make it so that it's more affordable. We'll go to the next slide. So like I shared earlier, January 7th was like any other typical day. And then right around the evening, started getting calls about fires approaching one of our clinics. Luckily, we're able to get everyone out. Everyone was safe. But we did lose that one clinic near the Eaton Canyon in Pasadena. But we also went into our incident commander, Paula Jameson, who's at Ultimed, really got us together. And we put together our own emergency response, knowing that the community was being severely impacted. So we served, I think there was up to a few thousand members, community members that ended up at the Pasadena Convention Center. And so we ended up setting up on-site clinic there with the full team and pivoted a lot of our resources to support those individuals in need. And really truly heroic. We were the first medical providers on site. So there was only the American Red Cross, which doesn't necessarily have medical providers, which I didn't know, and I learned. But everything from triaging patients that were coming directly from skilled nursing homes, folks that didn't have any medications or didn't have their life-saving types of devices that they needed. So our team did just a heroic job in really making sure that all those patients were safe, and luckily avoided many catastrophic challenges there. I'm just really proud of everyone. And then we continued until the evacuation center was obviously people were successfully able to transition to other places. But we're obviously opened up our other Pasadena clinics and continue doing great work there around some of those needs, and are now part of a broader recovery and response. And one of the, again, only federally qualified community health centers that's actually participating in this and really representing the needs of those patients that were adversely impacted, that are underserved. So we'll go to the next slide. So part of what we did about 5 years ago now is we set up a multitude of affiliate companies. One was obviously within the FQHC is Ultimed. We have our Ultimed Health Network, which is our restricted Knox-King, or where we can actually be delegated by a health plan to take on full risk. Then we have our Altura, which is our managed service organization. And that's really where they interface with the health plans and not only get us the right intelligence as a medical group, but they're also able to help us make sure we're getting credit for all the great work that we do in primary care. More importantly, they are the interface between our hospitals, our specialists, and ourselves. So as a primary care providers, we're able to really ensure that whatever's happening outside the walls of our clinic is being captured and that we're able to act on it. So when a patient goes to the ED, shortly soon we're able to know, or they're hospitalized and they get discharged, or they have any needs after that for specialty care, then we can really step in and take it on and not just leave it out to the patient to figure out, or to the community providers, the hospital or the specialist to sort out. But we take an active role in that. So that's through Altura. And then we also have a friendly PC. So for patients that are assigned to us that where we don't have a clinic, a federally qualified community clinic, we're able to contract with independent physicians in the community. And then, of course, we have our foundation. A lot of the gaps that still exist, we're able to bring in resources and support through the foundation. So this is really the infrastructure that has allowed us to then say, okay, how do you go from just getting paid fee for service as a federally qualified community health center and actually take on risk and be responsible for the specialty care, be responsible for paying not only the specialty care, but the hospital care or anything else outside of that one encounter in primary care. So this infrastructure is really what, and many others that we know across the country that have taken on global risk. You don't have to set up your own companies, but you can then bring in other companies to help you do this kind of work. But those, again, those types of inputs are critical if you're going to be taking care of patients at risk. We'll go to the next slide. So really, the approach we take is really through the eyes of our patients and understanding the experiences they have. I used to be a hospitalist, and so it was always very unfortunate to have a very sick patient come to the hospital, and we try to get a hold of the primary medical group, and no one would respond. So one, we couldn't have an adequate discharge plan, or if the patient was really sick and needed additional specialty, we didn't get enough support from the health plan either, or the medical group. And so you're kind of left, or the patient was really left with a lot of papers to figure out how to take on those extra steps. And that's really what we take on. We take on the burden of making sure that if you're an ultimate patient, or you will become an ultimate patient, that we become your full navigation system to really get through some of these challenges. And we also see it through our teams. Many of our teams, as I shared, not only reflect the community, they come from the community, they speak the language, but they live within a 5-mile radius. So many of our patients are actually family members. So they're also very helpful to us because they tell us where the gaps are. My mom got a mammogram and it's positive, and there's an appointment, but the specialist isn't for some reason responding, or they don't have an appointment soon enough, right? So those are, again, things that we've been able to collect and use as a way of saying we could do better. And this is how we at Ultimate can take care of making sure our patients don't fall through the cracks. And of course, our providers, they come, they're mission aligned. They've trained for many years. They want to come and work in a system where we don't say, here's where we draw the line, right? After here, it's someone else's problem. We really want to take on the full responsibility. And so at times it is frustrating if a hospital, for example, isn't providing us records. We keep saying, no, that's our responsibility. So we have to push and make sure we can get those records or systematize it so it comes through our electronic health record system. And it's not easy, but that's the expectation of our providers, is they want to be able to have the information they need to act on to support the team and of course, the patients. We'll go to the next slide. So one of the things I'm most proud of in the last several years is really starting to pull in a lot of data. Again, as we've gone full risk, we know what's happening even in the community. We know what's happening in the hospitals. We're seeing the claims come in from the specialists or different healthcare expenditures. We can use that through many different models, but the one we use is the Hopkins ACG model, where we're looking at, resource use, and we're able to risk stratify. So if you look at the chart here on the left, about 23% of our population is high or very high risk, meaning that, again, looking at the data, these are individuals that are demonstrating or showing based on a snapshot that they're using a lot of resources within healthcare, both outside and within our system as well. Problem list, different medications that are maybe higher risk and so on and so forth. And then the rest of our patients, about 26% or so, are low risk, and then everyone else, about 51%, are moderate risk. And so now we're able to not only take our population and risk stratify it, but we're also able to then look at what is that demographic, right? When we look at the age, about 40, they're about 46 years of age on average. 61% are female, 39% male. And again, on average, they have about 7 chronic conditions, and then we can even break it down further to see. And then not only are we able to understand our patients' population better in terms of their needs and use that as a way to design our health delivery system, or how we approach our care model for these patients, but we're also able to think about, well, what's happening when patients go to the ER, and we're able to now see that about 40% or so of those emergency department visits are avoidable, meaning that they could have been taken care of in primary care, but for whatever reason, the patients ended up in the emergency department. And then we can see what those diseases are, and again, go back and say, well, can we, within primary care, bring in some additional resources using global risk money instead of waiting for a fee-for-service visit to be able to invest in our own renal, for example, end-stage kidney disease program within Ultimate to be able to care for patients. So that's been, again, ways that we started to look at not only risk stratification, but the actual medical conditions that our patients are struggling the most and why they keep ending up in the ER or hospital, and then being able to come back and redesign our programs. We'll go to the next slide. So here we have, again, sort of the continuum. As I said, we have everything that's happening outside all the way within primary care. And then even within primary care, we're able to now leverage enhanced care coordination. Of course, ECM has been a huge, tremendous help, but also go beyond that. So we're able to coordinate even for those patients that are not maybe falling in the ECM category, but still need additional support, so they don't end up becoming higher risk and then having poorer outcomes. And then again, transitions of care, that's been another one where before we didn't think through, well, we could sort of think about setting up our own hospitalist program, but we didn't have the resources. But with, again, global risk, having additional dollars, we could set up our own hospitalist programs. And those hospitalists are employed by our federally qualified health center. So we're able to not only provide that care, but they also work in our clinics. So they come into the clinic and do post-discharge follow-ups. So they know the patient. They've seen them in the hospital and outside. And then our teams are able to be activated. We'll go to the next slide. And I'll just share a couple examples here, and then we'll wrap up and make sure there's some time for questions. So Ultimate, our Viva Gold senior program, this is a very different model compared to some of our general primary care. We actually have a concierge team that's available to our seniors, 62 plus, and then we're able to modify their panels. Instead of having 2,000 members per one provider, it's 900 patients for every physician, and they also have a nurse practitioner, an extender, to be able to care for those 900 patients. Now, we also have an extended team, of course, and the additional support. But this allows us then to focus on our more vulnerable patients, in this case, seniors, with higher social and clinical complexity, similar to PACE, but we do it in primary care, and we're able to achieve better outcomes. So we'll go to the next slide just to give you a snapshot. And again, these are from our performance as of November, so we'd have to go back and refresh this, but we definitely have a lot more members. This program's been around for about 2 years now. So we're closer to 2,300 members now that we've transitioned from traditional primary care into Viva Gold, our senior care program. And again, we could see that our emergency department rates are much less than, it's about 328 per thousand, compared to some of the state, DHCS puts out some of the rates for our Medis online, as well as we're looking at national Medicare benchmarks as well. So well below some of these benchmarks. And then again, we're looking at hospitalizations as well, so less hospitalizations. And then again, where we're still focused on is transitive care. So really making sure we're improving upon reducing our hospital readmissions. So again, now we can not only use risk stratification and then use a lot of the inputs from being full risk to better manage our patients, but get better outcomes and also hold ourselves accountable to these state or national benchmarks. So it's not just about the affordability, but can we really make sure that these patients are achieving better outcomes than others across the state or the country? And we'll go to the next slide. So enhanced care management, again, like many of our other partners, we're seeing a lot of the same successes again. The challenge is obviously a lot of the administrative hurdles that patients have to go through to stay in the program. But when you're able to overcome that, again, we're able to increase bonding with primary care and with the PCPs, the teams, but we're also able to see decreases in emergency hospital readmission and also improve quality, some of the HEDIS measures. Again, bringing on community health workers has been great. We've also learned a lot and taken the capacity building as well. Obviously, they're taking care of some of our sickest patients, so making sure we're addressing issues of engagement and turnover have been areas that we continue to learn and focus on to make sure that it's a sustainable program for Ultimate as well. So again, these are two examples. And then last, I'll say, if you go to the next slide, part of the lifeline has really been a lot of the investments in workforce. Our research department, as well as our medical education department, has really invested in not only taking youth, we have a lot of youth programs, but now we also have medical student rotations, as well as nurse practitioner rotations. And then now we have our family medicine residency program, as well as a nurse practitioner residency. And so we have the whole pipeline of folks coming into Ultimate where we can build a pathway to staying in the community at a federally qualified community health center. And they're able to see, again, this full value-based care model. And again, we have a lot of great stories of retention of folks that have gone through the pipeline and end up joining Ultimate and are now practicing in our clinics. But really, again, it's been a long view. Again, Ultimate's been around for over 55 years now. But I think the vision of our CEO has always been to make sure that we're increasing the capacity of our community and bringing them into healthcare. And this year, we just launched our nursing collaborative. So we're actually doing the same thing for nursing for the folks that want to go into nursing. And then we'll go to the next slide. So not only have we leveraged and really figured out that you can transform community by bringing in pipeline and, again, making sure that there's providers, especially in these heavily underserved areas or shortage areas, because we're always struggling with bringing on, or as we're growing too, bringing on more providers and nurses and staff, but also that in order to be successful in value-based care, using those lessons to train our own physicians. So about 5 years ago now, we started our site medical director university, SMDU. And that's where we started to have these conversations around how is it that as a medical provider, we're going to be responsible for all these outcomes. And again, there's a lot of questions around adverse selection of the population, or so many different challenges clinically, socially. But it was really our medical directors who really stood up and said, no, we want to achieve value-based care outcomes, but we want to learn how to do it. And so through this, we invest about 4 hours a month. Doesn't sound like much, but it adds up. We've been doing it for 5 years now. And we've actually had about 100% retention of our site medical directors over the last 5 years. Most of them that move on to senior positions. So they go on to regional medical director or executive physician leadership level positions. So it's been great to see. And these are the folks that, again, are helping us in the clinic in front of the patients to make sure that we're achieving these value-based care outcomes. And again, overcoming some of the fears or challenges when you hear about medical providers going full risk, especially in Medi-Cal, right? That's, I think, one of the lesser talked about areas where providers are going full risk. It's usually Medicare, but our first step was to go into this and do it for Medi-Cal. So we'll go to the next slide. It just talks about, again, risks, opportunities, but I do want to answer questions and make sure that I know there's a lot that I shared, but make sure there's time, and then I can cover some of this in answering questions if need be. So let me stop there. Thank you so much.
Yeah, Simona? We use the mic.
Yes, I got to do it this way. Okay. And I wanted to thank you for this amazing work. As a family doctor in Salinas, I really appreciate, all the things you're working on. My questions are in primary care. How are you scheduling the clinician? How do you deal with the tension between access and continuity? Because I noticed on your slide around the senior gold program that you did have this challenge with some of those patients not wanting to switch to another clinician, right? So it kind of speaks to that long-term relationship they've already had. So curious about that. And then the specialists, and how are you incenting for less utilization and high-value specialists, if you could speak to that.
Yeah, so I think for access and continuity, I do believe the data has helped us much more in terms of identifying patients where they're maybe not as engaged, right? And there are patients that are very engaged. And so finding that opportunity to understand why that patient may not be engaged. And in the example of a senior, many times it could be that they want to access their primary care provider more, but they're only able to do it, let's say, once every couple of months, right? Because the provider has so many patients, 2,000 patients paneled to them. So some of those patients are a lot more motivated that want to move to maybe a new program. They'll test drive it too, though. Sometimes they want to go back to their primary care physician. But also that our primary care physicians see the value of when they have patients that have higher clinical and social complexity, that they would benefit from a program like Viva Gold. So there is a lot of dependence on primary care providers giving us an endorsement. So that happens. But it also allows a primary care provider then to focus on those patients where they only have 20 minutes to see a patient. So that's where they can say, okay, well, if I have this patient with multiple chronic conditions and challenges, they keep going to the hospital, ER, it's better if they're in this program. Now, they can always access their primary care physician. Like they can come back and see me, for example, if they're in Viva Gold, but I'm no longer responsible for that full care. So that's one way we do it. And it's not perfect. I think it's still a work in progress. But continuity of care is something that I think even with the data we're using, we're still challenged. And we do get a lot of feedback from all our primary care physicians around we could always do better for continuity of care. When we do all the current financial model, I think is where we're really struggling. Now, where we're able to use full risk is we are able to change the paneling for the Viva Gold. We started with Medicare because we can really harness the Medi, decouple ourselves from just the fee for service and really use full risk dollars. What we're doing now is we're starting to develop that in the primary care setting where it's for all Medi-Cal patients. We have a very different model. And we do have a lot of primary care physicians raising their hand to say, hey, I don't want to be in the 2,000 per one doc model. I want to be in a team-based model, and I want to take care of higher risk patients with higher risk and complexity. So we'll see how that goes. But that's also another, I would say, big transformation for us. But again, the excitement for most PCPs is around, if you can help me with these patients who I'm really struggling with, then please, put them in that program. And again, the patient can always switch, right? That we don't want to take that choice away from the patient. Specialists, I would say that's probably specialists in hospitals is where we're really challenged, in that most of our contracting has been historically fee for service. And so one is that we get involved right up front. And so if we're starting to see patients seeing specialists for things that we can take care of in primary care, then we have a conversation with the patient, we have a conversation with the specialist, but it does take another set of resources like Altura or MSO to help us with that, because, we're taking care of the patients in front of us. So that's where it's be very handy. Now, where we're starting to move is we're moving a lot of our contracting to value-based care contracting with specialists. And that, I think, is where we're starting to see some yield. I have a patient during COVID, she was diagnosed with breast cancer, was able to get her into oncology, surgery, get her through her whole treatment, right? And was all synced up. I mean, it was probably one of the best experiences. And I've worked at academic medical centers. I've worked at some of the competitors around here, not too far from us, Kaiser. So again, it just really felt like, wow, like this is a patient who I didn't have to worry about as much as a PCP, because everything was set up. And all I was getting was a feedback around, this is what's done, here's the next step, here's the next step. So I think that's where we're headed, but it's not for every disease process yet. And I think that's where we're really trying to continue to push, is how do you do that, not only for cancer care, how do you do it for other types of conditions that need a lot of attention? Yeah.
Great.
But thank you for that.
We've got Stephen, Andrew, Hector, and Eliza.
Great presentation. Thank you for that. It really underscores the importance of global risk, global health budgets, and the flexibility you have within that to do some of these things. But following up on Sumana's question about specialists in hospitals, what data do you have available, or information do you have available to select relatively lower cost, higher quality specialists in hospitals? And what can be done to make that better for you? That's one. And then I have a follow-up question.
Yeah.
Go ahead.
Yeah, I would say that is, I mean, for the most part, we've been collecting and starting to analyze a lot of data now, because we've been doing global risk this is our 5th year now. But a lot of it started just with the rounding. I mean, really every day that we have a patient in the hospital, we're able to get the information from the hospital through the hospitalist reporting stuff to us. So we're able to quickly assess and determine whether or not that patient still meets criteria or should be in the hospital, or we can manage them at Ultimed. And a lot of it is, most of our hospitalists we have hospitalists that are Ultimed, we employed by Ultimed at Y Memorial Hospital in East LA and Beverly Hospital in East LA, which are both Adventist hospitals. So there we have a lot of data and intelligence, and again, it's forthcoming and being shared. But in most of our other hospitals, we don't have our own hospitalists. So we do, again, part of the contract is for them to work more closely with us every day to give us information. And as we're collecting that information, we're able to start discerning kind of what specialists in the hospital or what hospitalists are providing different levels of quality. But the biggest reassurance for most of those groups, even if you don't have a lot of this data, is that they feel confident they can discharge that patient and that you're going to take care of them. And so that's where I would say we've taken a lot of onus, is we can set up that cardiology, we can do the risk stratification, we can do all these procedures outpatient. That patient's not going to end up back in the hospital. It's a win-win for the hospital. It's again a win-win for us. But there isn't, I would say there is a void of data, real-time data that we can use to really assess hospital and specialist.
That's the way I interpret
quality.
your response.
Yeah.
You try to do your best through the contact
Yeah.
process, but you don't really have a
No.
transparency on quality, cost metrics of the utilization of inpatient and specialty care that your people have. So what about low value care? How do you identify and stay away from low value care and ensure that, that's not occurring in your practice?
Yeah. I mean, that is, I mean, we do have our medical education team that does a lot around bringing in speakers and also latest evidence around what is appropriate, what's not appropriate. We have our own ultimate clinician guidelines around this. We use that to then embed in the electronic health record system. So if someone's providing something that doesn't seem appropriate, they'll get an annoying alert. They can still override it, of course. But I think those are things that help. But it is, like I said, our medical directors are really the ones that in the clinic can really understand, are you over-referring? Are you under-referring? Are you over-diagnosing or under, right? And so we do get a lot of our rounding has to do with some of these questions around how are we performing, looking at measures that traditionally I would say in primary care, you don't necessarily look at, like emergency department visits. We look at hospitalizations, reasons for hospitalization, what was avoidable, what wasn't avoidable, readmissions. And then we also look at referrals. Per 1,000, we look at imaging, what kinds of imaging is being ordered. There's a lot of feedback involved. I would say, our greatest, I would say, like for providers who've been with us like over 5 years, we see a very drastic comparison versus those that are just starting with us and practicing the way we do. So retention's a huge threat and opportunity is to make sure that if you're investing so much in the medical provider group, to retain them, because once they learn how to do this, it's very hard to undo it, because they'll stop ordering all the unnecessary labs or diagnostics that they don't need.
A quick question on panel size, given workforce shortages, and so on. You mentioned in your gold program, you have panel size of 900 as opposed to usually around 2,000 or so. So what are your thoughts on how you're using AI or might be using generative AI to actually expand panel size, because you can free up some of the tasks, even clinical, not just administrative, certain clinical, therefore, and see more patients, spend more time with patients, particularly given the challenges of the workplace shortages we have.
We have not yet embedded AI in anything we're doing. We're actually in the process of evaluating, there's a lot of careful thought being put into it. But we do leverage a lot of our non-physicians right now behind the scenes. So, my teams are always commenting. We have several registries that when I talk to the medical leaders, they have more confidence sometimes in the medical registries not missing something and getting a hold of a patient, which is hard for us because we're in the clinic, we're seeing patients already. But if I have an alert on something positive, it's going to take me some time to get back to that. But our registry teams are able to act on it. And these are, MA, LVN, RN, and physician supervised folks. And they have teams and they're able to see the data, and they have the dashboards set up so that we're able to pick up on things. So we're, again, using a lot of people. I would say now maybe that we could use their skill set in a very different way if we were to implement AI, because there's still gaps that we have on the patient care side. But yeah, that's what we do now.
Okay, thank you.
Of course.
Thank you. Andrew?
Yeah, so there was a slide on your senior goal about home visit program and social health.
Yeah.
I was wondering if you can go one click down on those two.
Oh yeah, definitely. Yeah, so about 5 years ago as well, not only did we move towards having our own hospitalists, employing them, and then putting them at two of our busiest hospitals, But we also we're getting a lot of feedback from patients who were so sick that many times they couldn't leave their home. And so we developed our clinician home visitation program. And so now we span about we have 5 regions, right? We have a multitude, maybe about 2 home teams per region. And so every day they have lists of patients they actually go see at home. And then we also have a street medicine program that latches on to those regions that are able to go see patients that are not in an actual facility. They, home or facility. Sometimes they actually go see patients in facilities as well. So that's what our home visitation program does. And it really is that program, I would say for the most part, we do depend on providers making referrals, but that's where the risk stratification really comes in handy, because that's such an intense program that we really need to focus on the highest risk members to be able to be effective. And so that is a challenge. It's always like, we always want to add another home team, but what we try to do is say, okay, which of these patients that were being seen at home can we, take care of them a different way, right? Do we really have to send a doctor to their house or a nurse to their house? Can we send, someone else to their home to take care of them, right? Or do we bring them into our Viva Gold program, or do we bring them into our PACE program because they're so frail? So that's how we're trying to leverage that program, because it is very, I would say, the highest intensity, but also the highest resource, the highest cost. And they're only able to see maybe in LA, maybe about 6 patients a day per team, right? So we really have to be focused on the right patients. So it's been around, and again, we get a lot of great feedback from patients. Some are somewhat, very humble. They don't want people coming to their home, but we're able to convince them that it's because we want to take care of them. We don't want them to go back to the hospital. And so they trust us to go see them at home. Yeah.
Do Hector, Eliza, and then Parker.
Hi, Efrain. Great presentation. Great to see you.
Of course.
Couple questions. One is, you have a restricted Knox-Keene license, and do you foresee that enabling you to start capitating hospitals, number one, so they're more in alignment? And 2, do you foresee utilizing hospital at home strategies?
Yeah, I do think that's a huge opportunity, is evolving not only the specialty contracting approach, but also hospital. And I think that, capitation is one important way that we can better partner with hospitals, especially since we're, all in this underserved areas and taking care of common patients with a lot of the same challenges. So that is something that I know our medical group is very motivated. And then again, now leveraging our restricted Knox-Keene to be able to make that happen, so that these hospitals don't see us as a, there's a win-win basically in that capitation. And then your second question was about
hospital at home.
Yeah, hospital at home. Yeah, I mean, we have not looked at that yet. I know that was something we had a discussion about, but have not taken a deep dive in yet. But that might be another way, is not only to capitate with hospitals, but be able to partner with them on a hospital at home program. We do have some remote patient monitoring now, but a lot of challenges. I'm not sure it's working out exactly how we thought, but maybe the hospital at home program might be a better way to support, remote patient monitoring as well. So
great, thanks. And
thank you for that.
Separate question. You launched your initiative in 2018, moving from volume to value. Recognizing that in the FQHC world, the PPS tends to drive volume rather than the value to the patient. And you took a courageous leap, and you made great strides. Based on your presentation, it's fantastic. But it takes capital to make that transformation. What would you recommend to smaller FQHCs and smaller safety net practices in terms of finding that capital?
Yeah, I would say, we really leveraged, didn't mention it today, but we really leveraged our shared risk pools as a way to really move into full risk. And that was a lot of the lessons that helped us really position ourselves and also know how to make the math work, to make sure that we didn't just go full risk overnight. And then we started small. I remember it was like we started with 30,000 patients, which sounds like a lot. I mean, it was pretty scary to begin with. But now we're at 270,000 patients, or a little bit closer to 300,000 patients that have full risk now. So it's also like it didn't happen over 1 year. It happened over a multitude years. So I would say having a multi-year journey mapping where you can articulate, and Castelo did this very well for us, our CEO, and say, here's where we're starting, here's where we're going. And then really partnered with our physician leadership group to help us understand, well, what does that look like clinically? And I would say like what we look like today and where we are now is very different. And I would say, it's a little bit of a misnomer. I think for some conditions, there's a lot more volume that actually you generate. And there's a lot of conditions where we have made access to care very easy. I mean, you don't have to spend, a whole day trying to get to a PCP, right? If you're low to moderate risk, or you don't have all these other conditions. And so we've really tried to right size the amount of care and intensity of care based on how sick people are, right? So someone who's actually, has a rheumatological disease that's active may be seen once a week. I mean, they're seeing a lot more, and by multitude of teams, versus someone who is maybe otherwise healthy, 1 or 2 issues, they may be seen once or twice a year. And so we've really tried to shift the way we care for people. And so in some ways, I know sometimes I have to go and let the providers know and physicians know that we're still seeing a lot of people, but the way we're seeing them is very different today than what we were seeing them, 5 years ago. So not everybody has to spend the time to come in and see us if they don't have to. And again, telehealth has been a huge opportunity where we've been able to streamline care for people that don't necessarily need to take, again, hours upon day, a day to see us. So those are some of the, I think, the math, I think, helps in that you're still seeing a lot of patients. You're seeing them differently. The real opportunity that I've seen for us has been to leverage the non-providers as part of the team. And so what an MA does now, what an LVN does now, we're able to justify a lot more support for the providers than we used to on a fee-for-service only model with global risk. And to me, that is what is allowing us to reach some of these tougher outcomes in value-based care and the quality patient experience and so on and so forth.
Thank you, Eliza, and then Parker.
Thank you. Wonderful presentation. 3 quick questions. What level of clinician sees the patients at home is the first question. The second question is, can you do a click down on what your pay for value looks like for specialists? And then the third quick question is on the telehealth or the virtual visits. Do you use a vendor, or do you carve out time from your PCPs to kind of rotate and get to see patients virtually? Thank you.
Yeah, no problem. Yeah, for the clinician at home, it is mostly nurse practitioners. We do have a physician who oversees those teams, and they're able to attend to if the nurse practitioner, for whatever reason, needs help. They're able to switch out, and the physician can go see those patients. And those physicians have other responsibilities too, so they're able to help across the system in different ways. They might be in rounds for hospital rounds. They might be doing other things, so they can flex. Your second question was around the specialty pay for value. Yeah, I this is probably one of the areas that's the most underdeveloped. I do think what we've tried to do is with some of our like in for cancer care specifically, is we look at the patient, what's happening with our patients together, and then we're able to assess and share in some savings, right? If we're able to bring down ER hospital, not allow patients, like if the specialist can get to the treatment soon enough or get a procedure done, those kinds of things. But I would say it is an area where we're I would say there's still a lot more that we desire, and I think our specialists desire too. So it's a work in progress. We also look at what our health plans are paying us. And so if we're able to share for a specific condition where we did really well, we're able to share in some of that. But again, I would say this is for capitated P for value contracting with specialists. It's a handful compared to the many specialists we contract with. So it's the exception, not the rule yet. And then the telehealth. Yeah. So what we were able to do, given our scale about 2 years ago, is we actually have a 24/7 telehealth program that we built from within. And so again, our pipeline. So for example, for our nurse practitioner residency, we've retained 100% of our nurse practitioner for the last 3 years. So it's about, 6 to 8 per year. And a lot of them come into our system either floating or they offer telehealth, again, with the supervision of a physician. And so we offer our own 24/7 telehealth. I didn't include that in the slides, but we pretty much don't depend on a nurse advice line anymore. And what we started to notice right away was we were able to prevent a lot of patients being sent to the ED. So compared to, actually the nurse advice line we had, because they were routing those patients back to us, and we started to take over most of those calls, they actually went out of business, which again is unfortunate. But it also allowed us to see the value on the ER because we were not sending as many. They were sending, let's say, about 60-70% of patients to the ER every night. And we would only send 1 or 2, like 10%, maybe 15% to the ER. However, what we had to do as a primary care system was we had to offer these patients overnight an appointment the next morning. So it takes a lot of coordination and it takes a lot of effort to not only do the telehealth, because you can only reassure somebody so much, but actually having the ability to bring them into one of our clinics or urgent cares. So that has to be part, I think, of a successful telehealth program, is they have to have an entry point into your system. So even if you do get a vendor, which I know a lot of my colleagues who've brought in vendors, but there's got to be a very close communication, coordination to actual in-person, face-to-face care the next day or soon after. Otherwise, those patients will still end up going to the ER.
Thank you.
Yeah.
Parker?
Thanks, Efrain. Pretty inspirational talk you're giving us. And just for full disclosure, I went to med school with Efrain. He was the year ahead of me. And I am not the only person in my class who I have distinct memories of just kind of being in awe of him. He was a second year med student and already seemed like he just had med school figured out, and he was just kind of on another level. I think today's presentation is indicative of that. So I'm going to ask you it's the same question, 2 parts. I'm in FQHC, which is, we think it's the biggest one in Sonoma County. It's huge for us, but we're 40,000 patients. And we live and die, of course, by our Medi-Cal. Our logo Medi-Cal is the partnership health plan. And we are fully embedded in fee-for-service. And all of our quality measures, in fact, in my mind, further drive the fee-for-service concept, because they say, make sure you get a visit for this, make sure you get a visit for this. So we're always generating more visits. So the question is, how did you get your local Medi-Cal to buy into really shifting to a value model? And then if you have time, how also did you really get the clinicians on board with getting out of that mindset of we call it the rat wheel race, and embracing this concept? Because We're physicians who like the delusion of control
Right.
and working in team-based, right? You got to let go of a lot of things and believe that the system's going to work for you.
Yeah. Yeah, I would say, the health plans are very motivated. I do think when they look at how much they're spending on, ER, hospital care, or specialty care, they're more than willing to open up and say, how can we figure out what's a better arrangement? It does take a lot of, I would say, communication, partnership, looking at data together. I think that is something that I know our chief quality officer does quite a bit. And also feeling, I guess, having the courage to have the right conversation around some of that, to say, yes, we understand we got to hit these benchmarks. And I think that allows you then to be able to, set up the right arrangement around shared risk that can get you more comfortable to see what the world looks like, where it's not just maybe HEDIS based or, quality measure based. Two is that we did about six years ago now, we moved to Epic. And I wouldn't say it's about the electronic health record system, but what Epic has allowed us to do is put a lot more data in front of the provider and the nurses. And so everyone has their dash of what's being done, or let's say a registry team steps in to do something and we get a notification. That builds a lot of trust. And so one is, once you start sharing the right data with providers. So for example, our providers are still incentivized on HEDIS, for example. But if the HEDIS gets done, regardless of who gets it done, they still get the reward, right? And same thing for ER care, same thing for hospital care. So there's a mentality around, if we all, like, if I'm seeing your patient or you're seeing my patient and I can get everything done in that visit, then we're good, because you get the benefit. It's your patient, but I did the work. Now you see my patient, it's the same thing. And that took a lot of time, because there was a lot of distrust from the provider group, because it felt like you're not only moving people's cheese, but they couldn't see where it was, right? But once we started showing them the data, then they could say, you know what, I can spend more time on this, or I could spend more time on this, because I don't have to worry. All the vaccines have been taken care of. And not worrying again about, well, wait a minute, because all the vaccines got done means that this patient won't come back, right? And, our chief medical officer, Dr. Rico, will say, especially now, right, is we always talk about, you may not see this patient again. So you want to do everything you can to make sure you close every gap possible, because we cannot rely on them coming back again, right? Because of their social circumstance, because of, whatever circumstances they're going through, or they may lose their coverage, right? Now we can still see them, that the health plan's not going to give us credit for that. They may not pay us for that, but we still have the responsibility. So it is kind of that mentality from a leadership perspective, is being very open around partnerships with health plans. What are we really trying to achieve together? What does it look like to pay for this, so that we're not just stuck on a fee-for-service model? And then start wherever best meets where you're at, and then ensuring that the investments in the infrastructure allow for the data sharing and transparency with providers. And once they see that, it's very hard to undo, right? Now, I mean, the feedback we get, our physicians come to us and say, let's say there's a new nurse that starts. If they don't do everything like they're used to, it's the opposite. Now you're saying, why didn't you do all these things? I expect you to do all these things. And the nurse is like, I've never worked at a place like that. I'm usually waiting for the doctor to put in orders and tell me what to do. So I think those are the system changes that I've seen, at least in the last 7 years, where it's impressive to see how synced people are, and walk-ins, right? Or patients in need. Before it was like, oh, I'm full, I'm overloaded, I can't. And now it's like, no, if we don't see that patient, they're going to go to the ER. That's the mentality the whole team has in the clinic. So that's kind of the big culture shift around mentality. And I still think, you know, there's a lot of control that the physician still thinks they have, and, you know, but I do think like there's a lot more, like none of our physicians take call anymore, right? We have our 24/7 telehealth team take on after 5 p.m. or, you know, whatever time. And they know that Dr. Lomeli, who's our medical director, is overseeing all the providers at night. And if there's an issue, the doctor's going to get a call, right? And so then the next morning we have, this is what happened last night, like a cross coverage note. Here's what you need to do. And the physicians love that, because before the nurse advice line wouldn't even tell us. We wouldn't find out that the patient was in the ED till 90 days later, right? What can you do then, right? I think those are the changes that really allow for providers to really be engaged in this kind of value-based care world.
Go ahead.
I have two questions. The first one is for your patients enrolled in the Viva Gold senior care model. If how often can they see their providers? And then secondly, do they have any input on which provider they can see that is part of this group?
The second question is an easier one. That's what we're striving for, is we do want to build it so that it has where patients are able to select their provider. You know, we have what, 6 sites now. So 6 sites. So it is confined to certain geographic places right now based on where the clinic is or where the provider teams are. But we're expanding. I mean, we're planning to double in size by end of 26. So and it is an investment. Those clinics have to be updated facility-wise to be able to be a lot more friendly to our seniors. They're bigger rooms also, because a lot of times they're coming in with their caregivers and our family. So those are some of the things that take us a little bit longer. But also that for your first question, is that team is available every day. So if it comes down to they want to be seen every day for a few days, or maybe the provider says, you know what, let me try this, but I need to see you tomorrow, they're able to do that. And they almost guarantee same day access. I mean, unless someone's sick or someone's not there. But yeah, that is really the model, is it is a team that is accessible, or they activate the home visitation team, or they, you know, if the patient's in the hospital, we have our discharge planners go see them at bedside and things like that. So that's kind of, I would say, the more concierge approach to these patients that a lot of other patients don't have. We're starting to borrow from that to do this for our higher risk Medi-Cal patients that are not seniors, so under 62 years old, you know, the tougher age range between 40 and 60 that we, you know, most of us have a lot of challenges with. But yeah, it's almost, they could be there every day if they need it. Yeah.
Thank you. I think that concludes comments and questions from the committee on this item. Thank you very much. We will move to public comment on this item. If you'd like to make a comment, please step to the podium. If you are online, please raise your hand.
Thank you.
And while we're waiting for public comment, just really want to thank you for the presentation, coming to doing it for both the board and the advisory committee, and also for the wildfire response. So we appreciate your willingness to reschedule and for you being on the front line so quickly. Thank you.
Got one individual virtually. Beth, go ahead.
Hi, Beth Capel with Health Access, now remote. I apologize. Thank you. I just wanted to add our thanks for the presentation and the good discussion it prompted. These are the kind of examples that we hope others can learn from, and why we have patience with those who are trying. Thanks. Bye.
Thank you. Seeing no one at the podium, And no other hands raised, noting for the record, we have about 63 individuals attending virtually. That closes public comment on this item. We will move to the next item.
Good afternoon, everyone. Margaretta again. In this portion of our agenda, we'll provide an update on and review the feedback we received on the OCA Quality and Equity Measure Set proposal. And joining me this afternoon is Shanna King, the Health Equity and Quality Performance Group Manager, to present our proposal and the feedback we've received on the proposal via public comment and advisory committee discussions previously. So on the next slide, again, as we always do, starting with a reminder of statutory language that guides our proposed quality and equity measure set. So statute indicates that the office adopts the quality and equity measure set and that performance on the measure set must be included in OCA's annual reports. It requires OCA to adopt and track performance on a single set of standard measures for assessing quality and equity across payers, fully integrated delivery systems, hospitals, and physician organizations. And these non-enforceable measures will be used to monitor quality and equity trends and promote quality and equity as the spending targets are implemented. The statute also requires us to use recognized clinical quality, patient experience, patient safety, and utilization measures, and to consider available means for reliable measurement of disparities in healthcare, including race, ethnicity, sex, age, language, sexual orientation, and gender identity and disability status. And it directs OCA additionally to reduce administrative burden by selecting quality and equity measures that simplify reporting and align performance measurement with other payers, programs, and state agencies. The statute also directs OCA to coordinate with our fellow sibling departments and others like the DMHC, DHCS, Cover California, and CalPERS, and consult external organizations to guide our work. And then on this next slide, just wanted to talk a little bit about the context for the enforcement. So although OCA does not have enforcement authority, authority to enforce the OCA quality and equity measure set, statute specifies that OCA may require a healthcare entity to implement a performance improvement plan if spending targets are not met through our progressive enforcement process. And OCA's enabling statute prohibits the director from approving a performance improvement plan that proposes to meet spending targets in a way that are likely to erode access, quality, equity, or workforce stability. So accordingly, the director may consider performance on the quality and equity measure set when approving or disapproving a performance improvement plan. If we could go to the next slide, this is again a reminder of our purpose of the quality and equity measure set to really promote high value, high quality, more equitable care for all Californians, to monitor changes in quality and equity as healthcare entities work to meet the spending growth targets, and to track progress towards OCA's overall goals to improve access, affordability, and equity for all Californians. And on the next slide, again, this is a high-level overview of our proposed OCA quality and equity measure set. And in April 2025, so in next month, OCA is proposing to adopt all or a subset of these 3 publicly available measure sets and their respective stratification or grouping requirements to measure quality and equity across healthcare entities. For payers, we propose adopting the full Department of Managed Healthcare, DMHC's Health Equity and Quality Measure Set, and its respective stratification requirements to monitor disparities. And for physician organizations, we propose adopting a subset of the Center for Data Insights and Innovations Office of the Patient Advocate, or OPA, Healthcare Quality Report Card measures. And for hospitals, we propose adopting the full HCI Hospital Equity Measures Reporting Program measure set and its stratification requirements. And we will apply the same benchmarks used by each measure set owner to evaluate the performance of healthcare entities on these measures. And one of the notes we wanted to make here, based on our discussion with the advisory committee previously, is that in fall of 2025, after collaborating with sibling state departments, OCA will present a recommendation for adding hospital patient safety measures. And we'll share a bit more details about this process during today's presentation. And then also wanted to note that OCA, in addition, will continue to explore additional equity analyses beyond the stratification requirements by demographic characteristics used by the measure set owners. So we've presented in previous discussions some of the additional equity analyses that we could look at to complement this measure set, and we're continuing to explore those. And in the next few slides, we will review the measures included in the proposed measure set. So we can move to the next slide. So this slide and the next show the measures in our proposed measure set. So these include some of the best available access behavioral health outcome and patient-reported outcome or patient experience measures for payers and physician organizations. As we have noted before, the first 4 measures are also included in the OCA alternative payment model standards and are aligned across DMHC, DHCS, Covered California, and CalPERS. And we also want to note that the process measures on this slide focus on prevention and align with OCA's work promoting investment in primary care. I think our other note here is that we anticipate that the payer and physician organization measures that we propose will become more aligned as measures are added to the OPA healthcare quality report cards. So we anticipate that the OPA measure set will become more aligned with the DMHC measure set over time. And so we'll have a greater alignment for payer and physician organization measures. And then on this next slide, wanted to remind folks of the measures for hospitals. So this is in the HCI hospital equity measure set. So these include some of the best available behavioral health outcome, patient-reported outcome, or patient experience, safety, and structural measures for hospitals. Wanted to note that there is just one dedicated safety measure, as well as additional measures that promote overall patient safety. And as I noted previously, and we'll talk about a bit more, is that we propose to come back to you all in fall of 2025 with a recommendation for adding more hospital safety measures after collaborating with our sibling state departments on this effort. And before I turn it over to Jana, just on the next slide, want to recap where we are in the process. So this slide provides an overview of our process and tentative timeline for adopting the measure set. So in October, last October, we introduced our proposal and then to you all, and then we introduced it to the board in November. And in January, we provided an update on our proposal to you all and shared our proposal formally for public comment. So today we'll provide a summary of the feedback we received from the January Advisory Committee discussion and public comments, and the public comments we received. And then as a reminder, we are aiming to adopt this measure set in April. And this all leads up to OCA publishing its first annual report with quality and equity performance results by June 1st of 2027. So these results on this measure set will be included in OCA's first annual report. And with all of that context and background, I'll now turn it over to Jana to present background on our work to collaborate with sibling state departments on hospital safety measures and a summary of the feedback we received via advisory committee discussions and public comments.
Thank you, Margareta. Hi, everyone. My name is Jana King, and I use she, her pronouns. I'm the Health Equity and Quality Performance Group Manager at OCA, and it's nice to be with you all today. So OCA received feedback to consider adding healthcare associated infection, or HAI, measures to our quality and equity measure set, and more broadly to consider adding more hospital patient safety measures to improve our ability to monitor patient safety as hospitals work to meet spending targets. So in response, OCA will collaborate with sibling state departments, including Covered California and CalPERS, that are working to identify a priority set of hospital patient safety measures, including consideration of HAI measures. So the goal of this effort is to create an aligned approach to hospital patient safety measurement across state agencies. So OCA will review this priority set of hospital patient safety measures from sibling state departments, and will reconsider adding HAI measures and potentially other hospital patient safety measures to our measure set with input from you all and the board in fall 2025. We can go to the next slide, please. So on this slide, we provide background of the way healthcare-associated infection measures are currently being, or the way healthcare-associated infections are currently being tracked and reported across different state departments currently. So the California Department of Public Health, or CDPH, is required by statute to oversee the prevention, surveillance, reporting, and response to HAIs in California's hospitals and other healthcare facilities. So this is CLABSI, MRSA, VRE, CDI, and SSI, and I'll refer you to the slide for the full version of those HAI measures. One important note is that while CDPH actively tracks these HAIs, it does not stratify HAI measure performance by demographic characteristics. And then other state agencies are also prioritizing hospital patient safety through their contracts. The Covered California 2023 to 25 contract requires health plans to work with hospitals to improve performance on the same 5 HAIs as CDPH, though Covered California has removed a specific hospital measure list in the 2026 to 28 contract. And then similarly, the current CalPERS contract emphasizes improvement on 6 HAIs, 4 of which overlap with CDPH HAIs, though these specific measures may be removed in future contracts. We can go to the next slide, please. So now I'll turn to providing an overview of feedback that we received from the advisory committee from you all in January and public comments that we received. So this slide is a high-level summary of that feedback. Advisory committee members encouraged adding HAI measures, safety measures, and access measures. Advisory committee members encouraged more stratification requirements while noting challenges in collecting demographic data. Public comments shared general support for alignment efforts. Public comments recommended additions, modifications, and removal of measures. Public comments noted some limitations. Public comments recommended changes to the stratification requirements. And public comments requested that OCA consider innovative ways to utilize data for reports and delay or change public reporting requirements for some measures. And we can go to the next slide, please. Okay, so I'll start with a summary of January advisory committee feedback. This slide summarizes feedback related to measure set recommendations. Several advisory committee members encouraged OCA to include CDPH's healthcare-associated infection program measures and to consider adding more safety and access measures. OCA's response, as we've outlined, is that in fall 2025, after collaborating with sibling state departments, OCA will present a recommendation for adding hospital patient safety measures, and that the initial measure set is a starting point, and OCA is required by statute to regularly review and update it over time. We can go to the next slide, please. This slide summarizes feedback related to stratification. Advisory committee members noted challenges with physician organizations collecting and reporting demographic data and encouraged OCA to include disability in stratification categories. OCA will support and monitor statewide efforts to collect more complete demographic data, including stratifying measures by disability status. And OCA will review the overlap of physician organizations reported through total healthcare expenditures data submissions and those in the OPA healthcare quality report cards and explore ways to better align. OCA will also work with OPA and IHA to explore options to stratify measures by demographic factors. Okay, we can go to the next slide, please. And next we'll turn to public comments. So OCA received general support for using aligned measure sets in public comments. One commenter also specifically appreciated the inclusion of the prenatal and postpartum care measures. We can go to the next slide, please. So the next two slides summarize measure set recommendations from public comments. We received public comments to add measures, including healthcare-associated infection measures, access, outcome, and behavioral health measures. You can go to the next slide, please. We also received public comments to remove and modify measures as described on this slide. So in response to the measure set recommendations summarized on this slide and the previous slide, we note that OCA's statute requires that the OCA quality and equity measure set use recognized measures and leverage existing voluntary and required reporting to the greatest extent possible. So to that end, we're adopting measure sets already in use and aligning with those measure sets. In addition, as previously mentioned, OCA is required by statute to regularly review and update its measure set over time. So as changes to the respective measure sets that we are proposing to adopt are made, OCA will also consider adjustments to the OCA measure set. And we can go to the next slide, please. Addressing limitations of OCA's proposed measure set, public comments requested that OCA comprehensively capture important trends in access, quality, and equity, and indicated concerns with the CAHPS health plan survey, Getting Needed Care measure. So as we've discussed in prior meetings, OCA will continue to work with sibling state departments and other partners to evolve these measure sets and collaboratively address limitations. Next slide, please. This slide focuses on public comments related to stratification. Public comments included requests to clarify demographic characteristic categories, reduce stratification requirements for hospitals, but increase stratification requirements for physician organizations. Public comments also recommended OCA partner with research institutions and thoroughly review the measure set every 5 to 7 years as the measure sets evolve and the ability to stratify data improves. OCA will collaborate with stakeholders to reinforce and support efforts to have more complete demographic data from healthcare entities. We will support and monitor efforts to advance health equity and reduce health disparities, and will review and update our measure set over time. Go to the next slide, please. In this last summary slide, public comments shared concerns, provided recommendations, and requested delays in the reporting and enforcement of measures in the proposed OCA quality and equity measure set. OCA does not have enforcement authority for performance on the measure set, but will publicly report performance on the measure set and flag decreases in quality and equity in its annual reports, including for those entities that meet the spending targets. OCA will begin reporting on quality and equity performance in the June 2027 annual report. We will coordinate with measure set owners and healthcare entities on measure changes impacting reporting. Okay, go to the next slide, please. Okay, so this is our last slide of the section. Once again, this is a high-level overview of our proposed OCA quality and equity measure set. In April 2025, OCA is proposing to adopt all or a subset of these 3 publicly available measure sets and their respective stratification requirements to measure quality and equity across healthcare entities. In fall 2025, after collaborating with sibling state departments, OCA will present a recommendation for adding hospital patient safety measures. OCA will continue to explore including additional equity analyses beyond the stratification requirements by demographic characteristics used by the measure set owners. Thank you. We're happy to answer any questions.
Yes, thank you. Really appreciate all the work and the incorporation of feedback. As we previously discussed these, I appreciate the reconsideration on the CAHPS survey and going to sort of more meaningful surveys. I know this specifically referenced one measure, but I think when it comes to physician satisfaction surveys like Larry Green that really look at continuity and relationship are pretty important when we're trying to, create these value-based organizations. I also, back to, the equity lens and the conversation there, and we were talking a little earlier about this area. please do consider that organizations like Ultimed that achieve these measures with the population they have deserve additional recognition, so to speak, you know, to go out to farm workers, to send vans, to, you know, do all the innovative things that these kinds of organizations working with underserved populations do. It's one thing to achieve those metrics, but we have different populations, and I believe that we should take that into account in terms of further recognition or incentive, if you will. And then I know that we had talked about and made the point about HEDIS measures around vaccines earlier. But since we had that conversation, the landscape for immunization acceptance is changing dramatically, even in California. And I just wanted to highlight that for your consideration.
David? Yeah, thanks for this great work. First of all, I just wanted to re-emphasize it's so important that you align with existing metrics and don't create new ones. I know there'll be pressure to create new ones because there's always interest in creating additional measures, but a lot of this whole process we're in is about affordability and efficiency, and I'm really glad that you have not created new metrics. Every new metric creates more administrative burden, more complexity, more costs, so I'm really glad to see this. I want to make a comment about the childhood immunization metric specifically. In addition to the point already made by Suma about the politics and RFK Jr. and all that stuff, is going to make it, I think, harder for physician groups to achieve immunization status as they would like to. But the specific childhood immunization HEDIS metric is one that has 24 vaccine doses of 10 different vaccines. All must be administered in the first 2 years of life. It includes 2 doses of the influenza vaccine, which is not available in California between May and September usually. And so depending on the timing of the birth, it can be very difficult for a physician to be able to get the patient the flu vaccine, 2 doses of the flu vaccine. In addition, I think we need to be thoughtful about the pressure on physicians being measured on this metric when perhaps they have extremely vaccine skeptical parents who they're trying to overcome. So I would urge looking at the childhood immunization status measure, things like removing the flu vaccine, having a mechanism for parents who've opted out of vaccinating their children for that not to become a black mark on a physician group. I would consider. Last thing I'd say about equity is we've tried at Hill Physicians to collect race and ethnicity information. The most common response we get is decline to state. So it's just very difficult. I just think we've got to bear in mind and be practical about this. There's a lot of fear, unfortunately, I think, in patients revealing their ethnicity, even though we have good intent. I think as we think about these metrics, we've got to be really thoughtful about how do we make sure that we're recognizing the barriers.
Hey, David, on your first 2 points, I just want to square those. So you're saying we should leverage existing standards and appreciating that. And then you're saying, but this one, do it differently. So have you raised these issues?
Yes, thank you.
Oh, okay.
Thank you. I should have been more clear. So I am raising this. So I'm raising this same issue with Cover California, who is using the same metric. And any place I can, I hope the industry will adjust. So I'm hoping by these conversations, there'll be a consensus that we need to alter the childhood immunization metric. Thank you.
And then I'm surprised to hear what you're saying about the collecting race ethnicity data, because, my experience, and I've been on the front line assisting consumers, and my experience is most of the time, if you ask someone whom you're giving services to, they understand that it's for data. So you're saying more than half of your patients?
The most common single response is decline to state.
Okay. I'd love to hear more about that, because that's not been my experience.
There's a remarkable amount of paranoia out there about this information. Yeah.
You, Stephen?
Just hitchhiking on that just for a minute. It's not my question. I'm wondering if part of the difference here is if you have an opportunity to tell them why you're collecting the information, how it will benefit them, and even show a concrete case, I don't know, might help. And also the difference from what David is saying is a different metric than you're talking about too. He's just saying that among those who don't, that's the most important reason, but percentage-wise overall, it may be still a fairly high percentage that do give the information. So just clarity on that. But I do know the challenges when we do some of our field research and interview some of the practices, they comment on that as well. I want to just underscore David's point about a focused set of measures, over time is keep that in mind in terms of the administrative burden long run. But again, I really want to commend you on pursuing the hospital-acquired infections, because it's just so important to have a safety measure or a set of relevant safety measures that are routinely collected now. They're not an administrative burden. And it's great to get the alignment, absolutely, with Covered California, CalPERS, and others. I think you should be able to do that. You mentioned that CalPERS, and maybe it was one other, are thinking maybe longer run. They're not sure if they're going to keep it in their measurement set. It'd be interesting to know why that is. I mean, one reason would be if it's topped out. Everybody now has got hospital-acquired infections, really pretty low. That would be great. So maybe you don't need to collect it anymore. But that's a more generic suggestion also in the measurement set, right? Is to the extent that improvements are being made and they're holding constant, maybe one doesn't need to continue to include that in the all alignment measurement set. And I know that DMHC and some of the others are looking at that as well. He is, has grappled with that for some time now. Unfortunately, blood pressure control and blood sugar controls still aren't where it needs to be for so many people. So, but again, thank you for pursuing that.
Thank you, John.
I really appreciate that this is moving forward, and definitely supports starting with the standardized measure sets that are already out there and we're already moving towards. I do want to also reflect a little bit on the current federal state of play and how that factors in here in California, and want to just emphasize how incredibly important it is, the work that we're doing here to improve race and ethnicity data reporting, to improve immunization data reporting, with the concern that some of the federal data sets that we have relied on in the past, as with so many things where California is looking at the need to replicate something that the federal government has previously provided, would add healthcare demographic data into that mix. And so want to make sure that we are looking at this through the lens of making sure that California is taking care of our patients and our populations, and that we are collecting the data that we need in order to be able to best care for patients. And so appreciate that maybe these aren't all the metrics that we would want, but these are the ones that start from a low administrative burden, that start from already being in place in other settings, and would be hesitant with anything where we would be pulling back, or where we would be not trying to break through barriers on how are we on getting the best data, particularly race and ethnicity. Thank you.
Thank you. Additional comments and questions? Seeing none from our virtual committee member attendees, I think that concludes this item. We'll take public comment now. Step to the podium. If you're virtual, please raise your hand.
Hi there, Carrie Sanders with CPEN. Firstly, I want to thank OCA for adopting all or a subset of the 3 publicly available measure sets to measure health equity and quality by April 2025. This is very important to ensuring equitable quality access to care. We also appreciate OCA's response to calls for stronger reporting of demographic data and support their commitment or your commitment to monitoring statewide efforts, partnering with other agencies like OPA and IHA to explore opportunities to publicly report these measures. And as part of that, I appreciate the conversation about some providers finding it difficult to collect this data. Again, we know with the Health Research and Educational Toolkit, HRET, how important it is when collecting this data to explain why the data is being collected, as Stephen also mentioned, and to tie it back to, this is for healthcare quality. Your information is not going to be shared, but will make this experience better for everyone. Would also note that Cover California has reached 80% self-reported race ethnicity data, so it is possible when there's a commitment and when there are clear standards for providers, and others to follow. So we hope that this can be the beginning of, hopefully not the beginning, because we've been doing this for a while, but this can be an important step forward to getting to where we need to be across both public and commercial, the commercial markets. With regards to the patient safety measures, again, really appreciate adding those in and coming back in the fall. We hope that we can stick to that deadline, and we'll want to hear back. And obviously, we'd love to see that information stratified as well, to the extent that it can be. Thank you so much.
Thank you. Looking virtually, Beth, your hand's raised. Go ahead. Beth, we can't hear you on this end. You might need to unmute on your end. Beth, if you're there, we can't hear you. Try and unmute one more time.
Thank you. Sorry, my microphone was muted. Not by someone, I know not who. You would think by now I would understand how to do Teams. Beth Capel with Health Access. We want to support all of the things that Carrie Sanders from CPEN just said. We also appreciate looking forward to including the health-acquired infections. California has made important progress on that. We also want to recognize, as your presentation did, that the law requires the use of recognized measures, which is a limitation, but we would want to balance that, as Joan Allen said, by being as aggressive as possible and adopting new measures as they come online. We were discouraged in the DMHC equity quality discussion to discover how few measures there were related to behavioral health, which is obviously an important area for all of us and for OCA. And to continue to press the conversation on stratification, not only for race and ethnicity. It's the acronym is RELD SOGI: race, ethnicity, language, disability, sexual orientation, and gender identity. And all of those are important. And as we noted in our letter, so are things like housing instability, food insecurity, and caregiving responsibilities, all of which have well-demonstrated correlations with health or lack of it. And certainly things like disability status are known to health providers. So I think, as Carrie said, with more Cover California's gotten up to 80%. With some more work, we can get further. And we always prefer outcome measures rather than reliance on surveys that inherently rely on small samples. So this is continuing work, and we're glad the law requires you to update it every year, because we think that'll be important. Thank you.
Thank you. And as this is the last agenda item, this is also the general public comment period at this point. So if you would like to make a comment on any other agenda item, please step to the podium or raise your hand. Noting for the record, we have about 57 virtual attendees. Seeing no one at the podium at this time and no hands raised, that takes us to the end of our meeting. We are adjourned. Thank you.